of this lecture is to, the plan of this lecture is to tell you about nearly every single bone tumor. In the presentation, there will be many repetitions on cases, so that as you see them in the future, you will never forget the lesion. I will be taking between 2 and 3 breaks in the lecture. We have 660 slides to cover on this topic. So I will begin now. The incidence of both bone and soft tissue tumors is about 20 per million per year in the USA. But لازم تعرفوا how common these tumors are. They are very rare. And for this reason, you find that there are many institutions who hardly have any experience on bone tumors. By far, metastatic tumors are more frequent. There are new developments that occur every year and continue to occur in the area of primary neoplasia of bone. And of these is the understanding of the significance of genetic causes of neoplasia, as this would help distinguish between a benign and a malignant lesion when the histology is very similar. So these tumors have given us chaos. Many times we end up sending specimens from one pathologist to another, asking opinions right and left. Even the pathologists might wonder, could this be so and so? And they have to depend very often on the clinical presentation, on the radiology to get it put together. Now, it's very important, before I start this lecture, that this is a multidisciplinary form of treatment. We have to work together. You have to work together with the pathologist, with the radiologist, even with the pediatrician, even with an oncologist. You have to work together, and you should accept ideas from all. You should not follow a one-track system. You should accept many decisions that are helpful for the diagnosis of the tumor. Nowadays, in the past, we used to do many amputations, but nowadays it's rare. And when we do it, we only do it in cases where you have to treat the patient for pain, where he has metastasis everywhere, and the tumor is giving him pain, suffering. You will have to get rid of the tumor. Or in patients where you have operated and they recurred locally. If you plan your patient well, then the chances of recurrence drop tremendously. You should avoid treating these patients if you have no experience. You should always choose to send your patient to the proper place, to the proper surgeon who has experience in the management of this patient. Another important point, not every case who has mass, you decide to do a biopsy and then send him. This is wrong. You might do the biopsy in the improper place, and you will risk the survival of your patient. Bone tumors can be divided into primary and secondary. Secondary tumors can be further subdivided into metastatic tumors, tumors resulting from contiguous spread of adjacent soft tissue neoplasms, and tumors representing malignant transformation. We're getting benign lesions that we should develop an experience on them. What should we be aware of? because these benign tumors can undergo malignant transformation. Primary osteosarcoma and Ewing sarcoma are known to be tumors of children and young adults. Occurrence of chondrosarcomas in children or Ewing sarcoma in middle-aged patients and even elderly patients is typically unusual. The age is important. When you have a tumor in a child, there is a special differential diagnosis. And when you have it in the patients who are older than 40, there's another differential diagnosis. And at that age, you should think of a metastatic lesion. Of the primary bone tumors in this age group, multiple myeloma and chondrosarcoma are known to occur, particularly after the age of 50 and 60. Osteosarcomas at an older age, greater than 50, occur secondary to scar tissue. They can occur secondary to Paget's disease or even radiation therapy. So you have to think of this in your management of the patient and arriving at the proper diagnosis. مش all osteosarcomas are impossible to occur at this age. They do occur, but they occur secondary to other lesions. Giant cell tumor, a locally aggressive lesion, almost exclusively occurs in skeletally mature patients between 20 to 50 years. They are middle-aged patients. And we know that. So when you get such a lesion in such a place, you have to think of a giant cell tumor. It is practically never seen in children or patients older than 60 years. Why? Because this is a tumor that occurs when the epiphysis is fluid. And there is some argument that says that the giant cell tumor can arise partially in a metaphysis and then extend into the epiphyseal region. So you have to keep these in mind. Don't forget it. Why should one be aware of them? Why? Why? They are dramatic. Can you imagine yourself telling the family that your child has a malignant tumor? It's not easy. So it's swift and terrible in onset. It strikes young people. You see these young children suffering from pain. They have severe suffering. So you have to think of it. They produce disastrous effects on the lives of both the patient and the family. Improvement in management has saved both the extremity and life of the patient on many occasions. It is a challenge to the orthopedists and oncologists and all the rest of the group, the multidisciplinary group, and they should work together. I repeatedly say they should work together. There are centers that present their tumor early in the morning of a meeting, and they put the patient before any form of treatment. They make plans on the treatment. If they're going to do a biopsy, they make a plan on how they're going to do a biopsy. They make a plan on whether the tumor is a core or needle biopsy or an open biopsy. All these are important. But to do a biopsy before any radio imaging is done is a criminal act, okay? Because it will change the whole presentation of a tumor. So beware of this. What have we improved in this condition? Advances in the ability to identify this disease state, improved epidemiological studies, adjunctive treatments, improved imaging and staging. My God, we have so many radio imaging that we can do to arrive at the diagnosis. We can describe the lesion from all sides. We can take transaxial views. We can identify the soft tissue extension of the tumor. We can distinguish between tumor and edematous tissue. We can tell whether a patient is responding to chemotherapy or not. So keep this in mind. In addition, we are always after biological markers. This is the pathologist. Thanks to the pathologist who really attempt to help us arrive at the diagnosis. The genetic and identity of some tumors are very important to distinguish malignant from benign and how aggressive we're going to treat the patient or not. So be very careful about this. With improved immunoidentification systems and radio imaging, it has been possible not only to further classify many of the soft tissue tumors, but more from a clinical standpoint to identify and type the lymphomas primary in bone. Chemotherapeutic agents used with success. We all know about the cyclophosphamide, doxorubicin, actinomycin D, methotrexate, cisplatinum. These not only affected the local lesion, but also destroyed the micrometastasis and improved survival. The 5-year survival of both Ewing's and osteosarcoma has gone up to 60 to 70%. So imagine, in the past, they used to be between 10 and 15%. So you should imagine how much improvement has occurred. Radiation therapy has continued to be of help in Ewing's, not so much, because in Ewing's, you have the physis. If you give radiation, it could harm the extremity, and they will have a maldeformed extremity. Lymphomas, it is of help, and soft tissue sarcomas. Some of them, there is a good response to radiation therapy, but you should make the proper choice of treatment. The success of wedge resections of solitary and multiple nodules in the lung has allowed patients to survive for long periods without relapse. Specific markers are available that provide a significant diagnostic and prognostic value, namely alkaline phosphatase. It has been successfully used for osteosarcoma. Sedimentation rate and lactic dehydrogenase have been used in the prognostication of Ewing's sarcoma and osteosarcomas. So keep it in mind. If you're being examined, you should be able to mention these markers, mention the significance of an elevated sedimentation rate in a patient with Ewing's. And you kind of wonder, does this child have an infection, or does he have a Ewing's sarcoma? You have to know of an LDH, it prognosticates certain tumors. Don't forget this. A large number of immunologic, radionuclide, and biochemical markers have been devised to identify various tumors. Flow cytometry has been used in the past, at times in the present. It analyzes the DNA. It uses propedium iodide, and it is used to predict the biologic behavior and define the malignancy. It identifies abnormal clones of cells that show the phenomena of aneuploidy, of malignancy. It is the most common form, aneuploidy. It is common to have aneuploidy in malignancy. How do they present? They present with pain. If you're a busy orthopedic surgeon, it's impossible not to get the patient once in a while coming with the parents, with the child limping, and he tells you, I'm having pain in a particular region, around the knee, around the hip, around the leg or ankle, wherever the lesion is. The parents tell you that there's a change in gait. And if you palpate well, you have to examine your patient well. You palpate a mass. And the age, the very first thing you should ask about the age, because this helps you in separating certain tumors from other tumors. Giant cell tumors are more frequent in females. This is one of the rare bone tumors that is more frequent in females. Otherwise, males have been misfortunate than females. The far majority are more common in males. The race, Ewing sarcoma, is rare in blacks. If you look at an extremity and you see that it's venous engorgement, my God, with an increased temperature, you have to think of a tumor. And they can have unilateral edema. A child who presents with a pathologic fracture with no prior symptoms favors a benign lesion. Why? Because this child never had pain, and he was playing basketball and suddenly had a pain due to an insufficiency fracture. This is common to occur in unicameral bone cysts or any benign cyst which involves more than half the diameter of shaft of a bone or is larger than 2.5 centimeters in diameter. A gradually enlarging mass with increasing pain, especially at night. The family tells you, my child is not sleeping at night. He's crying and crying from pain. You have to think of a malignant lesion. Soft tissue tumors are most commonly painless. A rapid growing mass is mostly malignant. Fluid-filled masses are most commonly benign, especially when they transilluminate. And hard and large masses, especially if they're adherent and they don't move, that are progressively enlarging in size, you have to think of a malignant lesion. Increased local temperature is in favor of a malignant lesion. A fixed mass is from bone. If mobile, it's within muscle. So you might want to localize and tell the radiologist or the radio imaging group when they're doing an MRI, concentrate on this muscle, etc. Joint tenderness is in favor of an osteoma, neural tumors, and glomus tumors. I have seen, in my experience, numerous osteomas occurring in different places. I have seen very often glomus tumors occurring in the region of the nail bed, and in one patient I had it in the distal thigh. If you put your finger on the area of the tumor, the patient will jump up. There may be a reactive synovitis if the lesion is close to a joint. Vascular tumors fill up independent positions or may have inaudible bruit. Neural invasion is associated with paresthesia, stabbing pain, hypoesthesia, or motor weakness. On plain radiography, what should one concentrate on? First of all, the anatomic site of the lesion, the zone of transition between the lesion and the host bone, the internal radiographic characteristics of the lesion, namely the matrix. Look at the matrix. Lesion localized in the anterior elements of the spine, maybe a hemangioma. In the older patient, multiple myeloma. In the younger patient, histiocytosis X or eosinophilic granuloma. One must note the zone of transition between the tumor and the host. If one cannot note a clear boundaries, then the lesion is most likely aggressive. If well demarcated, then it is most likely a benign lesion. If you look at this lesion in the X-ray, you see that it's surrounded by a zone of sclerosis. There is a clear line of demarcation between the tumor and the host. So this most probably is a benign lesion. What about epiphyseal locations? What are the lesions that can occur? You have to think of a chondroblastoma. By the way, when we speak of epiphysis, it is the end of bone. The metaphysis is adjacent to the epiphysis, and the diaphysis is the shaft. So please have this in mind. Now, epiphyseal lesions are known to occur, and they can be either chondroblastoma, infection. I have seen eosinophilic granulomas occur in the epiphysis, giant cell tumors in the older aged patients. These are often centered in the epiphysis. Chondroblastoma is a rare tumor seen in children and adolescents with open growth plates. That's the difference. A chondroblastoma occurs with open epiphyseal lesions in the epiphysis. Giant cell tumor, the epiphysis is closed when it occurs, and it occurs in the older age group. Please don't forget this. So giant cell tumor is the most common tumor of the epiphysis in skeletally mature individuals with closed growth plates. Don't forget, closed growth plates. Giant cell tumor often shows metaphyseal extension. Okay, so please, if there's any questions, ask me. I'm not unwilling to answer any question. What about the metaphysis? The metaphysis is just adjacent to the epiphysis. And you have to look at the intramedullary lesions. What is common? A malignant lesion that we don't like, we hate to see, we hate to get the patient with it, osteosarcoma. It's usually found in the center of the metaphysis. In the center where I don't know whether the point is showing this, it's over here in this region. Chondrosarcoma and fibrosarcoma often present in the as metaphyseal lesions. Osteoblastoma, inchondroma, fibrous dysplasia, simple bone cysts, and aneurysmal bone cysts. There are benign lesions, and they are common to occur in the metaphysis. So never forget this. Metaphyseal lesions centered in the cortex. The previous lesions, we said that they are centered in the intramedullary cavity. Metaphyseal lesions are centered in the cortex. The classic location for non-ossifying fibromas, we do see these very often in growing children, defects in the cortex. They are also known to be involved, the cortex, in osteomas. What about metaphyseal exostosis? Osteochondroma is known to grow out from the metaphysis. It has the same medullary cavity as the mother bone. What about diaphyseal intramedullary lesions? Ewing sarcoma, lymphoma, myeloma, and it's common for fibrous dysplasia and inchondroma to be present. So I want you to think of, remember the location in which tumors occur. This will help you. Remember the age in which the tumor occurs. These are important points that would help you make a diagnosis. Also, we have diaphyseal lesions which are centered in the cortex. And this is adamantinoma and osteoma. What about radiographic assessment? Plain radiograph. I think it's very important. I really would kill a resident who comes asking for an MRI without asking for a plain radiograph. A plain radiograph is the first imaging technique for a suspected bone lesion, since it is inexpensive and easily obtainable. It is also the best for assessment of the general radiologic features of the tumor. This is very important. Many times, I would say in 75 to 80%, I can make a diagnosis of a tumor by means of a plain radiograph. Before going into these fancy radio imaging techniques, computer tomography. These are questions we love to ask. What does computer tomography help us in tumors? It assists in lesions that are permeative and destructive, and it will tell us about lesions in certain anatomic regions that we cannot reach. If you take a plain radiograph of a lesion in the pelvis or sacrum, there is overshadowing, and you won't be able to tell the details of the lesion. A CT scan helps and tells us it. It also tells us whether the lesion is cystic and fatty. Don't forget, CT is very important for regions which are difficult to reach. And it tells us about the bony component of the tumor, tells us about the cortex. Is the cortex eroded? So you have to keep this in mind. Now, you have to realize that on plain radiography, I put this up because I felt it's very important. It will tell us if a lesion on the left upper hand side is solid, cloud-like, or ivory-like. All these will give you characters of certain tumors. Likewise, you have to think the ground glass, which occurs in fibrous dysplasia, solid bone infarcts, cloud-like appearance, which can occur in osteosarcoma, ivory-like also, the coarse trabecular-like or the sunburst appearance. All these, and about the the bone marrow matrix or the marrow matrix or the matrix of the tumor, whether it's a popcorn, whether it's various shapes, or whether you have a sunburst appearance or a onion peel appearance. All these will tell you about the character of the tumor. In this, you see that there is a mouse-eaten appearance. You note the zones of demarcation between the tumor. If you look on the left-hand side, you have multiple myeloma. It's a mouse-eaten, it's punched out osteolytic appearance. This tells you that the tumor is aggressive. On the right-hand side, you see a non-ossifying fibroma, where you see that there is a clear demarcation between the tumor and the surrounding bone. Over here, in this X-ray, you would see that usually giant cell tumors occur on one side of the epiphysis and metaphysis. You see you have a lytic lesion, but the boundaries are not very clear. They're vague. So this would tell you Is this tumor latent? Is it active? Is it aggressive? Okay? In addition, in these tumors, you should always look at the cortex to see whether it's eroded. Then it would tell you more and more that these lesions are aggressive. Whenever you see calcification within a tumor, you should think of a cartilaginous tumor. In this patient, you can see that within the lesion, you have calcification. So don't forget this. MRI is a method of choice for local staging. It is superior to CT in the definition of medullary and extracortical spread. It tells us about skip lesions. What I mean by skip lesion is a spread of the tumor to another area with normal tissue in between. It tells us about satellite lesions. It tells us about the soft tissue tumor component of a primary bone lesion, whether it has penetrated that compartment and gone to another compartment. In other ways, it tells us about the staging of a tumor. MRI appearances of the majority of bone tumors are totally non-specific. You need to examine plain films or CT films to define a neoplasm. MRI tells us about the soft tissue and the intramedullary component, while the others give us more details about it. Gadolinium-enhanced imaging is often used to assess tumor necrosis. Especially in patients that you're giving them chemotherapy, you want to see the tumor to the chemotherapy. What about bone scintigraphy? We used to use it more often in the past, but it still has help. It is a highly sensitive but relatively non-specific technique. Its main role is in detection of suspected metastasis in the whole skeleton. It's helpful in the detection of osteodystomas, especially in the spine and pelvis. Patients coming with such lesions and symptomatology, a scintigraphy might localize them and they will help us, and it will give us the double density sign. What I mean by double, where you have a decreased uptake, then you have an increased uptake. And in the center, you have calcification. This is typical of an osteodystoma. One should evaluate bone formation and flow. Normal scans favor benign tumors. إذا عندك enchondroma, which is benign, if you do a scan on it, the uptake will be low. If you have an increased uptake, you should worry about it. At one of these bone tumor conferences, we were talking about this, where we know that many enchondromas can be benign, can be low-grade chondrosarcomas. If we do a scintigraphy and we have an increased uptake, it would let us worry about it. So it helps in distinguishing between benign tumors. Hot benign tumors include, you have to keep this in mind also, osteoblastoma, osteoma, aneurysmal bone cyst, and fibrous dysplasia. If you do a technetium scan for a patient with multiple myeloma, an increased uptake, insufficiency fraction, and even in eosinophilic granuloma, it won't have an uptake because it's osteolytic. You have to know that scintigraphy shows an increased uptake when you have an increased blood supply to the lesion and when you have bone formation. Gallium scans are used in the evaluation of soft tissue tumors. Don't forget this. Yeah. Now, what are the questions asked? What is the precise location of the lesion, as I mentioned? The type of bone. You have to think of whether you have flat bones and long bones. There are certain tumors which occur in flat bones, certain tumors occur in long bone. Where exactly is the lesion center? Keep this in mind. That's what I've been talking on for the past 3/4 of an hour. The epiphysis, some tumors almost exclusively occur at specific sites. Many others favor certain locations. Is there any evidence of underlying bone abnormality? You have to look at the bone in general. You should see if there are infarcts. You should look for Paget's disease, which is a known precursor of tumor. High-grade sarcomas tend to arise in damaged bone. Is the lesion multifocal or not? You have to pay attention to this. Now, does the tumor have a well-defined margin that I spoke to you? If you look at the X-ray behind, you see an aneurysmal bone cyst, but it has a shell, it has a coverage. Look at the matrix, you see multiple loculations. That's why you don't see a sagging bone sign, a fracture of bone settling down. Why? Because you have multiple loculations. You cannot pass. So you should look for a rim of sclerosis, the presence of a margin and a sclerotic rim strongly suggests a benign, non-growing. Is there evidence of significant expansion? These findings are seen with locally aggressive and malignant tumors. So if you want, as a resident, and you want to describe these points, you should memorize and then describe them. Is there an associated periosteal reaction? If so, type. We know that Ewing sarcoma gives us imperial appearance. And then it forms bone, and then it forms bone. بتبين مثل قشرة البصلة. And you have a sunburst appearance, and you have a hair on end appearance. What we mean by hair on end is when the tumor is pushing the periosteum up, the vessels become perpendicular, and so bone forms around the vessels. This is the hair on end appearance. Does the lesion produce mineralized matrix, osteoid, or cartilage? This is important. Is there a soft tissue mass? This is very important. This would tell us of how aggressive the tumor is. The patterns of growth and bone destruction. Before I go in, would you like, anyone has any question? في حدا بيحب يسأل؟ في حدا بيحب نوضح أكثر؟ شو؟ خالد، في حدا بيحب يسأل شيء؟ Am I clear so far? يا دكتور خالد. يا دكتور خالد, am I clear?
دكتور جون.
ايه واضح؟ فسرنا.
اي واضح، كل شيء واضح، والشباب يعني متابعين تمام. واذا في سؤال هم بيسالوا. اذا في سؤال
شو السؤال؟
ها؟
في شيء سؤال؟
لا يعني هم بيجمعوا اسئله. طيب. بعدين
طيب بدي الشباب يفتحوا عينيهم ويفتحوا دينيهم ويسمعوا، لان هدول الاسئله عم بقول لكم كيف نسال. بدكم تعرفوا كيف نسال بالبورد لحتى تجاوبوا. make use pay attention. وبعدين انا رح بزعل من حدا يلي ما حضر هاللكشر، لان عم بعطيكم الطرايق يلي بنسال بالبورد. ما في عندكم نازل ما تعرفوا عن البون تيومر لما عم نفحص، أنا هالمرة رح تكون عم بفحص، لما عم بفحص وشفت حدا ما قدر يجاوب اشياء بفسركم اياهم وحياتك رح بسقطوا. They have to understand this.
يستاهل.
طيب. Benign and non-growing or extremely slow-growing lesions are well circumscribed and they show a geographic pattern. لازم تعرفوا الفرق ما بين ال geographic pattern, the moth-eaten pattern, the sclerotic pattern. هدول مهمين تعرفوهم. When you find a zone of sclerosis around the lesion, it's a geographic pattern. If you get eaten up bone and you cannot tell differences in locations of the lesions and you have a vague separation, this is a moth-eaten appearance, an aggressive pattern. Okay, so the sclerotic rim is more commonly seen in the weight-bearing bones and represents bone reaction to the lesion. Its presence means that the bone has been given sufficient time to react, meaning that the tumor is growing slowly. The sclerotic rim signifies benignancy to about 95%. So this is very important to know. If the lesion is growing more rapidly, it may still show a well-demarcated zone of bone destruction, and it still is a geographic pattern, but it will lack a sclerotic rim. طلعوا بهالtumor. Tumor is benign, but it's still, you have a clear boundary, but it is vague. Okay? Expansile growth pattern is defined as visible widening of the affected portion of bone, like occurs within aneurysmal bone cysts, at times with the unicameral bone cysts, at times within enchondroma. It might appear wider. In many cases, an interrupted periosteal rim will surround the expanded portion of bone. This pattern may be seen in locally aggressive tumors and in low-grade malignancies. Rapidly growing lesions are poorly defined and may show aggressive, infiltrative patterns of bone destruction, permeative or moth-eaten. Moth-eaten pattern is defined as an ill-defined zone, multiple small radiolucencies that may coalesce. Permeative pattern is characterized by numerous tiny radiolucencies in between the residual bone trabeculae. طلعوا بهالصورة، طلعوا بالmedullary cavity. شوفوا small lesions. من برا you see that the tumor has penetrated the cortex and you see the hair on end appearance. The vessels become perpendicular to the cortex and they form bone around it. Due to the minute size of radiolucencies, the lesion may be difficult to see and to delineate on the plain film. Generally, the more rapidly growing a lesion, the more difficult it is to see on plain film. Moth-eaten and permeative patterns are indicative of destruction involving both the medullary and cortical bone. And these are known to occur in malignant neoplasms. And even be aware, osteomyelitis can cause it. So don't forget this. Calcification. Most likely a cartilaginous lesion appears more heavy and dense than ossification. بيسألونا ونحن بدنا نسألكم how would you tell whether it's calcification or bone within the lesion? If you look at the X-ray above, you see that bone, the lesion is more dense. Okay, it's more dense and has irregular than ossification. It may destroy the cortex and even elevate the periosteum with an angle known as Codman's triangle. And this tells you that the lesion is an aggressive lesion. Don't forget this. This is the Codman's triangle, periosteum. But a warning sign. إذا عم تاخذوا البيوبسي ما تاخذوها من Codman's triangle لأن what it will be only bone and you might diagnose a malignant tumor as being benign. You should not take the biopsy from Codman's triangle. A biopsy should be taken at the periphery of the lesion because it is the active phase of growth of the lesion. Centrally, it's necrotic. It may elevate the periosteum without destroying it and be an aneurysmal bone cyst, what we call ballooning out. مثل البالون عم ينفخ من العظم. Or it can be a fibrous dysplasia or an chondroma, as I mentioned. Whenever there is a soft tissue mass associated with the tumor, it favors a malignant lesion. In the upper hand left side, you see an enchondroma in the middle phalanx of a finger. How can you do it? Look at the calcification within the lesion. And you should know that enchondromas are very common to involve the hand and the feet. But you see that there's a haphazard, an irregular calcification. In the X-ray on the upper right-hand side, you should see an osteolytic lesion. There's no calcification. Therefore, it's not cartilaginous. And it is in the proximal tibia. It is in the epiphysis. You have to think of a giant cell tumor, which has eroded the cortex in the X-ray or the axial cut in the X-ray and the MRI below. Okay, or CT, I'm sorry. But this is something. You have to look for calcification. Calcification, it's cartilaginous. When you have erosion of the, I think, an aggressive lesion. Types of periosteal reaction. Slow-growing tumors provoke focal cortical thickening. Solid periosteal reaction or buttress. So I repeat, slow-growing tumors provoke focal cortical thickening. Rapidly growing lesions penetrate through the cortex, causing separation of the periosteum and formation of lamellated new bone. If the periosteum elevates to a significant degree, it can break, forming an acute angle. This is called Codman's triangle at the site of the arrows in the X-ray. This is seen in malignant bone tumors and in some other rapidly growing lesions, such as aneurysmal bone cysts, or in reactive processes like osteomyelitis and subperiosteal hematoma. Codman's triangle is usually free of tumor unless infiltrated through the open end or by a transcortical approach. This shows you a tumor. You see a sunburst appearance. The tumor is in the diaphragm. This patient had a Ewing sarcoma. This is another patient with an osteosarcoma. You can see that there is a sunburst appearance, and it's speculated. And this is what we call hair on end types. In Ewing sarcoma, you see layers of preosteal reaction. It gives you the onion peel appearance. The patterns of matrix mineralization. I will take 4 minutes or 5 minutes break. Go into this. Smart Khalid, I'm going to take a 5 minutes break. Khalid. خالد
ها دكتور جون.
راح باخذ 5 دقائق بريك.
اوكي
لان كل ساعه بدي يكون عندي نفس.
اوكي خذ راحتك.
Okay, we're going to start. Yalla. The patterns of matrix mineralization. Malignant osteoid can be recognized radiologically as cloud-like or ill-defined amorphous densities with haphazard mineralization. This pattern is seen typically in osteosarcoma, mature osteoid, or organized bone shows more orderly trabecular pattern of ossification. And this will point it for a benign. But look at this X-ray. You see it as a cloudy appearance, And this, you have to think of the presentation of an osteosarcoma where the osteoid is haphazardly produced. So don't forget this. What about chondroid? Cartilage, as opposed to osteoid, is recognized by the presence of focal stippled or flocculent densities in lobulated areas as rings or arcs of calcifications. Rings or arcs of calcifications. They are best demonstrated by CT scans. Whatever the pattern, it only suggests the histologic nature of the cartilage and nothing else. It does not differentiate between benign and malignant cartilaginous lesions. But later on, you'll see that if you have rarefaction around these calcifications and scalloping of the cortex, it will pinpoint that it is most likely an aggressive presentation. There are conditions that one may confuse with a malignancy. And I recall a case of a patient when I was training in Canada. The patient had a stress fracture, and they took a biopsy from the site of the lesion, and the diagnosis was an osteosarcoma. An amputation, an above-knee amputation was done. I'm speaking of a time of 50 years ago. And later on, the pathologic response was that it was a stress fracture. The family raised a lawsuit against the hospital. At that time, they got $1 million. Paget's disease and brown tumors can be confused with a tumor. A brown tumor occurs, as we know, in hyperparathyroidism, bone infarcts, pigmented villonodular synovitis, and bone infections. These can all be confused with the malignancy. The three basic types of information that should be obtained prior to surgery are the extent or local and distant spread of the tumor. This you should get from radio imaging. You should do a full workup on the patient before the pathology is obtained. And you should make sure that there's no metastasis. You have to do a CT of the lung. You have to evaluate the patient as a whole. But the pathology is the last process to be done. The biopsy. The benign lesions include, we classify them into 3 stages. Stage 1 is inactive. We call it latent. And an example of this is non-ossifying fibroma. Stage 2 is active. An example would be an enchondroma and aneurysmal bone cyst. Stage 3 is aggressive. And an example is giant cell tumor and chondromyxoid fibroma. So never forget, if they want you to classify benign tumors, you should say that there are 3 stages: the latent, the active, and the aggressive form. What are the characteristics of benign tumors? They vary in behavior. Many only need observation. Some may undergo malignant transformation and even metastasize. They are well evaluated by radiographs in 2 planes. It usually remains confined to the natural barrier. They may expand bone and only on rare occasions may penetrate the cortex and extend into the soft tissues. It is usually surrounded by a dense sclerotic margin and a clear demarcation between the lesion and normal. Plain X-rays. What should one look for? Favor a benign, a malignant lesion, as I repeatedly said. A sunburst appearance, a hair on end. This forms around vessels, perpendicular to the cortex, following periosteal elevation, and this favors a malignant lesion. The soft tissue extension exists, which favors a malignant lesion. The consistency of the lesion is important, whether it's lytic, blastic, or calcified, will give us an idea about the type of lesion one could be dealing with. Gentlemen, I'm telling you this, and if there are ladies among you, I'm repeatedly mentioning many points. These should be stuck in your head, not to forget the details of a bone tumor. Please bear with me. I'm repeating certain points. On plain X-rays, we mentioned about the gradual zone of transition. Don't forget this. And don't forget about the site of the lesion. Don't forget about the gradual zone of transition. Malignant lesions, you should know the histology and activity. But before you do a radio imaging prior to any biopsy, a grade 1 lesion, the ratio of the cell to matrix is increased with a 25% chance for distant metastasis. Grade 2 is more than 25% chance for distant metastasis. There is a high cell to matrix ratio with pleomorphism and anaplasia. The pathologist will tell you about it. Whenever you see pleomorphism, whenever you see that there is hyperchromatism, whenever you see atypical mitosis, then you should think of this is an aggressive lesion. Also, we depend on the size. Metastasis to regional lymph nodes and lungs indicates distant spread of the tumor. The investigation includes a full laboratory workup. An elevated sedimentation rate may indicate a poor prognosis for patients with Ewing sarcoma and lymphoma. Plain X-rays provide significant information on how aggressive the tumor is. It tells us whether the lesion is surrounded by sclerotic, as we mentioned. Less sclerosis is more aggressive. Aggressive if it infiltrates the cortex. Many osseous lesions can be adequately identified with a plain X-ray. One should be able to distinguish between calcification and ossification of what I told you in this lecture. Calcification appears more dense, and I repeatedly don't forget this. This is a question we routinely ask. We show an X-ray with a lesion within mass, within bone, and the calcification to tell us it's a cartilaginous lesion, not a bony lesion. One should aim at reaching the following prior to definitive surgery: the location, the extent of how spread, and about the pathologic diagnosis. About scintigraphy, we spoke. We will not go into it anymore. And you should never forget that multiple myeloma and eosinophilic granuloma don't take an increased uptake on technetium scintigraphy. In a gallium scintigram, if the uptake of it is normal, the lesion is more likely benign. Arteria don't use that often nowadays. Nowadays, we use them only for embolization, or if we don't get a clear picture of an MRI of the lesion's relationship with the vessels, then use an arteriogram. It is a basic procedure, but it provides information on the relation of the tumor tissue component. The MRI would tell you about the soft tissue mass and edema and satellite lesions or skip lesions. Magnetic resonance imaging is uses a magnetic field to measure the response of the tissue protons to radio frequency. You should know about what are T1, T2. You should know the detailed imaging of a magnetic resonance imaging. When would you use fat suppression? When won't you? And of how you can help you on telling you the response to treatment. You have to think that most tumors have an intermediate signal on T1 weighted imaging, which contrasts with high signal on compared with intermuscular fat pads. Most tumors have a high signal on T2 weighted imaging, a feature that is used from lower signal of adjacent soft muscle tissue. Don't forget about the transverse imaging planes, which are helpful, especially for us surgeons. These planes allow radiologists and surgeons to identify anatomic compartments for adequate surgical planning. Blind X-rays include most of the early bone marrow replacement processes as well as soft tissues. MRI easily evaluates these tissues for the presence or absence of tumor. MRI can also characterize the tumors in certain cases, in benign or malignant. Soft tissue sarcomas are frequently depicted on MRI as masses with irregular margins and heterogeneous T1 and or T2 signal. Benign soft tissue tumors or masses on MRI are likely to show increased T1 signal. Examples include lipoma, hematoma, and hemangioma. Most liposarcomas have an appearance similar to other non-lipomatous sarcomas. Hematomas often have a peripheral rim of increased T1 signal. On gradient echo images, radiologists should look for a dark rim of associated hemosiderin. However, care must be taken to exclude the underlying tumor that is obscured by the of it. I've had the malignant or an undifferentiated sarcoma in a woman, a girl, 17 years old, where the patient had the mass in the thigh, and the radiologist mentioned that the MRI was indicative of an athletic injury with hematoma formation. Later on, the mass continued to grow. I did a repeated MRI, and it turned out to be malignant fibrous histiocytoma. The radiologist should be aware of this. Malignant tumors rarely have low signal on T2 weighted images. A desmoid tumor can be locally aggressive and may recur. The tumor itself is benign and does not demonstrate T2 masses, include areas of hemorrhage, malformation, and foreign bodies. entities should be considered. These include neurogenic tumors, metastatic lesions, and desmoid tumors. A group of musculoskeletal tumors and tumor-like conditions that can be detected and characterized by MRI include synovial or ganglion cysts. They can as high signal on T2 weighted and display low signal on T1 weighted images. Neurogenic tumors and myxomas demonstrate uniform high T2 signal and have proton density or T1 signal that is increased relative to the adjacent muscle. Patients with lymphedema show soft tissue thickening in the reticular pattern in the subcutaneous fats. Bone infarcts show a characteristic low signal intensity band on T1 weighted images. Several patients who have left to right muscle asymmetry that was thought to be a tumor on non-MRI studies are diagnosed. You have to be careful. By nature, there are certain patients who have enlargement of one buttocks with respect to the other. And this, you should be aware that this could be very normal. The most common site of this size is are low in T1 signal and may present in up to 25% of elderly women. They have masses underneath the scapula, which is mainly of elastic tissue. What about the biopsy? So we finished from the first topic. We finished from the evaluation of a tumor. We're coming to the final stage by doing a biopsy. The biopsy, you can do an incisional, excisional, you can do a final nasal biopsy, you can do a core biopsy with the help of fluoroscopy, etc. Without a well-planned biopsy would lead to adverse effects on the prognosis and treatment of these tumors. Please pay attention. Prior to any biopsy, should be performed. In other words, the staging studies should be complete. At determination of the staging, if a patient is noted to have a malignant appearing bone tumor, it would be advisable to refer him to an experienced orthopedic oncologist. What should one aim for while doing an open biopsy? The incision should be small, but adequate. Obtain a sufficient specimen for arriving at the diagnosis. And what I do is I always take a frozen section from the specimens that I've taken to make sure that I've taken the biopsy from the tumor. I aim at taking a biopsy at the periphery of the lesion, not in the center. The periphery of the lesion is the diagnostic region and not the central position, as it would be necrotic. Don't crush the specimen. Don't take multiple specimens, as this would promote spillage of the control. Now, if you're doing an open biopsy, the incision should be longitudinal. If you're doing an open biopsy, it should be done at the site of the definitive surgery, because you need to excise that lesion. The least differentiated portion of the tumor should be biopsied, as detected by CT scans and MRI, as this area would be most representative of the tumor. I was at once a conference, and the pathologist was saying very proud that we do an open biopsy. This is wrong. This is wrong. And if you recall, in the first third of my session, I spoke about Codman's triangle. And we don't like to take our biopsy from Codman's triangle, as here we have reactive bone, and it may be misinterpreted as osteosarcoma. Don't biopsy bone unless you really have to, because it is the soft tissue component of the tumor which would represent the tumor fully. If the bone is biopsied, make a small opening to avoid complications, because one of the problems in the past, routinely we used to biopsy the bone. What did we have? We had insufficiency fractures. And if you're forced to biopsy the bone, you should protect it with an external splint. You should prevent hematoma. If difficult, one may use gel foam or missile site of the biopsy. Do not use a hemovac, as the tumor may spread along the drain tubes. If you have a large amount of bleeding that you cannot control and you want to pass a hemovac, you should pass it through the end of the incision and not through the skin. The incision, I stressed, it should be longitudinal and not transverse. Many times we had to do an amputation where the surgeon did the transverse biopsy. It should be excised with the definitive surgery, and the best way to excise it is by having a longitudinal incision. As used, meticulous hemostasis should be performed following its release. A frozen section should always be taken from the non-mineralized soft tissue component of the tumor. What help does biopsy provide? Provides DNA for cytologic evaluation and microscopy, or a block of tissue for formalin fixation, standard hematoxylin and eosin stain, microscopy in centers that have it, and put glutaraldehyde. Segment should be sent for aerobic and anaerobic cultures, and for the study of fungus and acid-fast organisms, because these can be confused with malignant tumors. A small segment of tissue for hormone receptors, especially if the lesion is thought to represent a small segment of tissue for flow cytometry, now a routine at a number of centers who have it available. A round cell lesion cannot be interpreted accurately from a frozen section. A lesion that has classic appearance of osteosarcoma and treated by immediate definitive surgery in the centers who have experience on doing it. They have a number of cases and they develop their experience in diagnosis. A competent pathologist can usually distinguish a well-differentiated cartilage tumor from an aggressive one, but is rarely able to go on frozen section. No lesion should have an open biopsy without a frozen section interpretation and consultation with the pathologist. Usually when I'm taking a biopsy, I usually have the pathologist on the door of the operating room with his microscope. He does a frozen section and it tells me whether I removed the specimen. It's not like an embarrassing situation where you take a biopsy and it doesn't show the site of the lesion. A second biopsy of a lesion, because the initial biopsy did not sample the tumor, but only revealed the reactive margin of the tissue obtained was necrotic or not diagnostic, jeopardizes the patient's ultimate care and result. To perform an open biopsy in the shiny, thin, overlying skin of an underlying neoplasm is to invite wound complications. Do not squeeze the lesion prior to surgery for fear of embolization. Prevent bleeding from the lesion as it transplants tumor cells with the effect of radiation therapy, which now we rarely use. What is ideal is to perform frozen section and then perform the definitive surgery prior to releasing the tourniquet. This could occur at a Mayo Clinic or one of these huge clinics well acquainted with biopsies and diagnosis. The reactive lesion zone about a lesion within bone is much easier to recognize than one about the soft tissues. The reactive zone is recognized early by radioactive scanning and late by cell X-ray. It also may be recognized by fluorescent tetracycline given 3 days prior to the surgery. It was to leave biopsy incision without excision due to its improper location, and no recurrence has occurred prior to 2 years, it can be assumed to have escaped from recurrence, as 95% would recur prior to 2 years following the biopsy. The biopsy incision or path should be well planned in accordance with the plan and approach to be used in the definite surgery. The incision should be longitudinal. No plans should go down. The better it is. The shorter the path, the less seeding of the tumor will occur. Once the definitive surgery is planned, it should be in such a way that the biopsy scar and root be included in the definitive surgery approach. This principle should also be applicable for the fine needle or core biopsies. The needle root should be excised during the definitive surgery. You should tattoo the area where the needle is placed. All indicate that it is the surgeon who is to perform the definitive surgery to be the one to take the biopsy. We come to the individual bone tumors. بعرف زهقناكم أول شيء بس هلا we're coming. Any questions? يا جماعة, before I go into the individual tumors, are there any questions يا جماعة?
Dr. John?
Yes. No question.
These are patient who has demonstrated this is the osteosarcoma. The compensation upon who? Upon the histopathologist or upon the
all put together.
all
First of
together?
all, the surgeon should know where the fracture is common to occur. He knows the plain X-ray, which would last. Which one is the tumor osteoblast and which is not? The pathologist should be well aware what is the tumor osteoid tissue. The tumor, you see, there is a difference between the osteoid tissue from bone fractures and the osteoid tissue of a tumor. If you look at the osteoid tissue in the matrix, you will see that it is surrounded by irregular, hyperchromatic osteoblasts. We usually identify the abnormal osteoid tissue by looking at the lining cells. So you have to pay attention. This should be studied very carefully so as not to have this complication. And this.
But sometimes there is not a stress fracture. For example, it is. It looks like there is some patient. They are taken for this patient. Fine needle aspiration, and they told that is benign lesion. There was no destruction. There was no significant behavior for the malignancy, just like benign. Then they did surgery.
Like benign.
Yeah, it looks like benign.
There are certain cases, really. That's why we have many pathology opinions, Khali. We have in the USA, when they get there is very limited experience on the tumors.
Yeah.
And for this reason, you have to use so many diagnostic points to back you in your diagnosis. That's why I started with the evaluation of bone tumors. You will have to use a CT scan, MRI, do pathology, do evaluation, etc. And then usually you arrive at a diagnosis. But many times you cannot have a definitive diagnosis. There have been many cases which have been missed, saying that it's a benign. For instance, aneurysmal bone cysts are known to occur on malignant lesions. I have had a case of an apparent aneurysmal bone cyst of the thoracic 12 vertebra. A core biopsy was taken and sent to one of the most prominent pathologists. And he said, this is a benign lesion and it's an aneurysmal bone cyst. At operation, we removed the vertebral body and we were making plans to go from behind to do fixation so as to stabilize the spine further. Suddenly, we get a call from the pathologist saying that he was mistaken, that this was an aneurysmal bone cyst growing on a malignant osteosarcoma. So we had to change the whole treatment, and this was sad for the patient. If we had known it was an osteosarcoma, we would have done it in one stage, removed the vertebral body anteriorly, and then went from behind and did a complete resection of the vertebral body. So this is what I'm trying to say. There are many questions that are unanswered, and it's well known that stress fractures have been confused around the world with osteosarcoma, and you have to be very alert. You have to know the site where stress fractures are common to occur. You have to know it. For instance, ballet dancers get it around the fibula. There are some people who get it around the tibia, the proximal end. You have to know the site. You have to be aware of.
Okay.
Okay? Thank you.
Okay, thank you, doctor.
Benign bone tumors. Let's start with unicameral bone cyst. It is a solitary lytic lesion of bone located in the metaphysis. Pay attention. In the metaphysis. It occurs most commonly in the proximal humerus in 50% of the cases. In the femur, 20%, and between 4 and 12 years. Males to females are 2 to 1. Rarely it has occurred in the calcaneus. It is known to be associated with an insufficiency fracture, and patients would tell you, we never had pain. We were playing basketball and suddenly we had severe pain. And you take an X-ray like in this humerus, have an insufficiency fracture secondary to the cystic lesion that is present in the metaphysis. This is a unicameral bone cyst. On occasion, one may notice a fragment of bone to be sinking within the depths of the cyst. You see it over here. You see this fragment. This is what we call the sagging bone sign. This we can use to differentiate from an aneurysmal bone cyst. Why? Because this does not occur in an aneurysmal bone cyst, which is full of loculations. This will prevent a bone, when fractured, to settle down to the base. So this is one of the differentiating points between a unicameral bone cyst and an aneurysmal bone cyst. In the aneurysmal bone cyst, it would be impossible for a fragment of bone to sink due to loculations. What I mean by loculations, multiple cyst-like cavities separated by septa that are present within the cyst. This is known as the sagging fragment sign. Many times we ask this question, multiple choice questions. What is the sagging fragment sign? We put multiple points, 5, and we tell them choose 1 out of 5. You have to keep this in mind. Unicameral bone cysts are most common around the age of 8 to 12 years, and is more frequent in boys than present with pathologic fractures on minor trauma with no history of any previous pain. They are believed to be due to venous obstruction, most accepted, release of interleukins and prostaglandins, and if you aspirate the cyst, it's straw-colored. While if you aspirate an aneurysmal bone cyst, it's bloody. This is the second differential point. If you aspirate a cyst, an aneurysmal bone cyst, due to locations, you see it's full of blood, you get blood. While that of a unicameral bone cyst, it's straw color. A lining of fibrocytes and collagen dispersed among these are giant cells and hemorrhagic areas. Cholesterol and fat cells are also seen. We see this in the pathology. And the treatment is, once the diagnosis is made, the cyst should be aspirated and sent to cytology, followed by local infiltration of steroid or autologous bone marrow aspirate. But let me tell you, this is when there is no fracture. When there is a fracture, you should wait for the fracture to heal. And if it does not, because there are a certain number of patients who have a unicameral bone cyst, the fracture heals following, and the cyst would gradually disappear. So you have to wait. If you find that the cyst is still present and is growing in size and causing much deformity, then you should inject steroids and autologous bone marrow. The steroids should be at large doses. I usually inject around 160 milligrams of steroids, methylprednisolone, and I do it on 2 or 3 occasions, and I've had subsidence of the cyst. Radiopaque material should be confirmed that the whole cyst is filled with the dipomedrol or the methylprednisolone, and that the septa does not interfere, as this is associated with a high recurrence. 2 to 3 injections every 2 months are required. If the patient does not respond, an open curettage, biopsy, and bone grafting should be performed, but this is rarely needed. This is a unicameral bone cyst. Where is it localized? It's localized down. This tells you that this child is nearly closed physis, and the cyst is closing or filling up, and tells you that the chances for it to progress are less. The closer the unicameral bone cyst is to the physis within the metastasis, the more likely it will be active and likely to progress. So don't forget this. A more aggressive cyst with incomplete loculations and expansion of the cortex, it should be distinguished from an aneurysmal bone cyst, as I mentioned. The cyst was carotid and grafted. Now, what do we see on pathology? It consists of a lining of fibrocytes and collagen dispersed among this area of giant cells and hemorrhagic areas with cholesterol and fat cells. At both universities, the American universities, we encourage our residents to rotate in the pathology in relation to bone as possible, because a good orthopedic surgeon should have an idea of how a giant cell looks, of how fibrocytes look, of how a hemosiderin-laden cell would look, and where hyperchromatism is present and where mitosis is present. With time, unless you see them on the microscope, you study them carefully, you will not know them. Where I trained in Canada, we were forced to rotate 2 months through the pathology department to make the reports on all tumor tissue. We had to learn how the cells are presented, the difference between cells. And believe me, it has helped me tremendously over the years that I have worked in. And I hope that you people will do the same. So, in conclusion, unicameral bone cysts are benign lesions. They are most commonly affecting the proximal humerus and involves the metastasis and diaphysis of long bones. I have seen it in the proximal end of the femur. In this case, we have to protect them from weight bearing. I used to infiltrate them and put them in a hip spiker. Why? Because I would be afraid from an insufficiency fracture. It's called on bone scan. If Dr. Michael, one of our residents at AUB, is attending, he would have seen, he has attended a case presentation and now staff meeting at the American University of Beirut of a cartilaginous tumor where there was much argument about how to tell whether it's aggressive or not. If you look at the unicameral bone cyst, of course, it looks benign on plain X. If you look at the unicameral bone cyst, you don't need to do a scan. But if you do a bone scan and you see that it is inactive, then you would say that this is definitely a cyst. But if you see that is active bone formation, you have to be aware of. And I would always like to warn you of an aneurysmal bone cyst with no insufficiency fracture on a vague lesion, and it shows an increased uptake. You should investigate further and make sure that this is not an aneurysmal bone cyst growing on a malignant lesion. Treatment consists, as I mentioned, aspiration, biopsy, radiopaque dye, flushing, and injection with methylprednisolone, as I mentioned. Intralesional injections of autogenous bone marrow also help. Let me tell you that because you are mostly young orthopedic surgeons, when you get such a cyst, it can occur in flat bones, it can occur in the humerus. What I do, I put 2 large needles. I put 18 gauge needles. Or at times I use the through cut needles. I put one from both ends. In one, I inject physiologic saline. The other, I aspirate. I aspirate all the fluid. I do it repeatedly. Then I inject alcohol, and I do it. Following this, I then inject normal saline, and I aspirate. Finally, I will put the methylprednisolone in. But before doing this, I inject dye to make sure I'm filling out the full area. Filling out the full area. Because if you fill out one area and leave the other out, it will recur. Autogenous bone graft has helped. So don't forget, unicameral bone cysts do occur in the proximal femur. This is bound to fracture, especially if you want to make a hole to make your injection. I routinely put them in a hip spiker and do the injections. I don't want an insufficiency fracture to develop in these cases. You should know that they are slowly growing, they are expansile, but usually a unicameral bone cyst does not expand as much as in aneurysmal bone cyst, which forms a balloon. The specimen was labeled cyst wall that was obtained and consisted of scant fragments of rubbery white gray tissue. Microscopic examination showed bland, fibrous tissue with sparse inflammatory infiltrate, hemosiderin, hemosiderin-laden macrophages, and occasional osteoclast-like multi-giant cells. So if you look at this specimen on a microscope and you enlarge it, you should look and find some fibrous tissue. You should find hemosiderin, brown-laden macrophages. You can see giant cell tumors, giant cells present, sorry. This is a larger view. The specimen was labeled cyst wall and consists of scant fragments of rubber white gray tissue. Examination showed fibrous tissue with inflammatory infiltrate, hemosiderin-laden macrophages, and occasional osteoclast-like multinucleated giant cells. So don't forget this. In the long bones, at times a unicameral bone cyst is called a solitary bone cyst. Characteristically involves the metaphysis and diaphysis. Other possible skeletal sites are the ilium, as I showed you, the talus, and calcaneus. Don't forget this. If you get a lytic lesion, you should always put it in the differential diagnosis when it occurs in the talus or calcaneus. The differential diagnosis, you should be aware of the cystic nature of the lesion. Ask the surgeon to his eye. The lesion is a cavity filled with clear fluid. This will help you to avoid misdiagnosis of a solitary cyst as being a solid lesion. We don't like to see solid lesions because they more likely are metastatic, are malignant lesions. The clinical behavior is benign. It's slow growing. The pathologic fracture is a common component. Rare cases of secondary malignancy being reported, chondrosarcoma have been reported. You should keep this in mind. Aneurysmal bone cyst. Any questions on unicameral bone cysts? The way you treat them, you put 2 needles. If you have a fracture, you wait until it heals, because still, if you want to treat the patient and the lesion did not heal, you put 2 large needles, measuring 18 in size. One you aspirate, the other you inject. You inject either alcohol or autogenous bone material which is obtained from the marrow cavity, because it will stimulate it to heal. Or if you don't want this, you will inject methylprednisolone into the lesion. If it is in the hip, you put a hip spiker. Why? Because it is bound to fracture. To distinguish it from an aneurysmal bone cyst, in unicameral bone cysts, they don't have so many loculations. In aneurysmal bone cysts, they do. In unicameral bone cysts, there's not too much expansion of bone. In aneurysmal bone cysts, there is. In unicameral bone, the fluid is brown or light brown. In aneurysmal bone cysts, it is bloody. Aneurysmal bosses may occur at any time during growth, but is most often seen in children and young adults. It is considered a primary neoplastic condition or secondary to arteriovenous malformation. It's an expansile lesion. It erodes the cortex, but is continuously surrounded by a thin shell of bone. It is described as a blowout appearance. Others describe it as a soap bubble appearance, مثل الصابون. And you find that there are many loculations. It gives you a soap bubble appearance. لازم تفكروا فيها. So it's expansile, it can blow out like a balloon, and it can be a soap bubble appearance. This X-ray on the left lower hand side shows you a large aneurysmal bosses occurring in a child. You see that there are multiple loculations. It has not penetrated the cortex. The cortex is still telling us that it seems to be a benign lesion, not occurring on a malignant lesion. On the right-hand side, you see another aneurysmal bosses occurring in the outer end of the clavicle, and it's ballooning out, ballooning out. Aneurysmal bosses can occur in any bone. And this is how, if you take a gross specimen, you see the spongy expansile lesion containing multiple blood-filled cavities of varying sizes. So you have to never forget this. Okay, please, never forget this. What about the pathological findings? This is a low-power view demonstrating blood-filled cystic spaces without recognizable epithelial lining. The septa are composed of vascular, fibrous tissue containing multiple osteoclast-like giant cells, inflammatory cells, and extravasated RBCs, red blood cells. The high-power view shows uniform but mitotically active stroma cells. However, no atypical mitoses were identified. The periphery of the lesion shows pushed down, curved trabeculae of pre-existing lamellar bone. It most commonly affects in 50%, namely the metaphysis, followed by the spine, 25%, and the rest distributed among all other bones in the body. When in long bones, it may extend through the physis. Spine, it may extend from one vertebral body to the other. And if it is in the posterior arches, it can involve several vertebrae, as I will show you in two of my private patients. It may rise alone or on previous lesions, such as what I have repeatedly mentioned: chondromyxoid fibroma, non-ossifying fibroma, chondrosarcomas, and osteosarcoma. So be aware of aneurysmal bosses because they cannot not always be benign. You can miss it. 60% are primary and rest secondary to the above lesions. lumbar area, the posterior arches, but the vertebral bodies may also be involved. It may extend from one vertebral body to another, and scintigraphy reveals an increased uptake at the periphery of the cyst. Why? Because this is the site where you have activity. Definitely in the center, there's far less. These are two cases of mine where the patient once, one 11 years old, and the other was, I think, 14, where I had aneurysmal bone cysts occurring in the posterior arches, one in the L3, the other one in L2, 3, and 4. So that gives you a balloon-like appearance. The tissue obtained is reddish-brown in color, as I showed you in this specimen that was shown to you at the beginning of this condition. Numerous vessels are seen, and you have to keep in mind, please, that aneurysmal bone cysts lack in elastic lamina. They lack it. They don't have in the basement membrane in elastic lamina. One should always search for an associated lesion, and hemosiderin is seen in giant cells and macrophages. This shows you that there is no elastic membrane, and you see numerous bleeding throughout. Total excision lesions located in regions with the rib or carotid and bone grafting in other locations, such as the radius or tibia. Cementation, cryosurgery, or embolization should also be considered. So you have to think of it. We used to give them radiation. Nowadays, we try our best to avoid giving radiation. We try to remove the lesion surgically. This is an aneurysmal bone cyst that was excised. Have a look. This will tell you that you won't get a sagging bone sign. Why? Because any fracture will be blocked by the septa of the loculations. So don't forget this. And it's full of blood, while in unicameral bone cysts, it's a straw-colored fluid. This shows you giant cells and blood. It shows you the vascular spaces lined with fibroblastic cells and collagen. Giant cells with hemosiderin and osteoid tissue. And likewise, these show you the giant cells that exist. This is an aneurysmal bone cyst of the proximal fibula. Over here, this is an expandable bone. And what I will do, I would excise it, but leaving the physis in place. I would try not to divide the physis, but wherever you have an expandable bone with an aneurysmal bone cyst, like in the rib, like in the fibula, like in other regions, like in the ilium, try your best to excise it as one block, because the incidence of recurrence is high. If you see, recurrence rate following curettage is 50%. Hemangioma bone. You know that 11% of the population worldwide have hemangiomas of the vertebra. Most commonly occurs in the thoracic spine, low down, and you see that if you do an axial cut, it appears like the honeycombed appearance of the bees. You see, this is typical, 11%, and it usually involves the vertebral body. So don't forget this. I have had 2 cases of hemangiomas in long bones, and the differential diagnosis was osteosarcoma. Luckily, one was of the distal end of the femur that I resected. Turned out to be a hemangioma, and I applied autografts and allografts to fill out the defect, and they healed. One was in the tibia, the diaphysis of the tibia. So you have to remember that these enter differential diagnosis of other lesions like osteosarcoma. Okay? They are detected by chance. Okay? Over here, what I give is 12%, but to the best of my knowledge, it's 11%. Watson et al. On reviewing 1,000 cases of vascular tumors treated at the Memorial Hospital noted that only 5 had involved bone. And I will tell you, I have had 2 cases. Of these 3 involved in the literature, and noted that 2/3 were in the skull or vertebral column, and only 1/4 were in long bones. This shows you how a hemangioma looks in long bone. If it's in the forearm, as is shown over here, you can see that there are 2 in the film on the right side. You should be careful. Lesions present as such. But these cases were my cases that I had in the tibia presented as such, and 1 case in the femur. In the case of the femur, we thought that it was an osteosarcoma. Hemangiomas of bone are far more common in the vertebral body. Extraspinal location is rare, but more commonly occur in the craniofacial bones, the humerus, metatarsus, and metacarpals. 2 of our cases, one occurred in the distal femur, and the other occurred in the diaphyseal, metaphyseal region of the tibia. These lesions, when present in bone, most commonly involve the diaphyseal, metaphyseal region. Periosteal hemangiomas of long bone have been reported and are small lesions, usually localized to the metaphyseal and mid-diaphyseal regions. On plain X-rays, one may see a sun ray appearance with evidence of fine spicules of reactive new bone radiating from the periphery of the lesion. It may give rise to fusiform or localized expansion of bone, usually at the end of bone with thinning of the outer cortex, little periosteal reaction. Unconventional radiography and CT, hypertrophic bone circulation, cortical expansion, irregular intralesional speculation, and lytic zones are often seen. This is an MRI which reveals high signal intensity on both T1 and T2 weighted images due to fat content and blood products within it. The differential diagnosis of any of the diaphyseal, metaphyseal lesions consists of osteomyelitis, osteosarcoma, Ewing sarcoma, metabolic disturbances such as Gaucher's disease of bone. One should be aware if a radiological appearance of a scalloped or a hyperplastic sun ray appearance lesion is noted in the cortical region at the end of bone and always include a hemangioma of bone differential diagnosis. They may be very solid, and in one of our cases, it was hard even to resect with a saw. تعذبنا كتير لحتى نقدر نشيل the distal end of the femur. We left the joint in because it was at the diaphyseal metaphyseal. We did an intercalary resection because the diagnosis of biopsy was kind of equivocal. We were not sure of what the lesion was. So we resected it, interposed it with the autograft and allograft. I removed the fibula, and the patient luckily healed. Okay, so you have to be careful that you're not dealing with one of the malignant lesions. A mass in the first web is shown in the X-ray on the higher level. This is punctate calcification. It's known as phlebolith. And this can occur in association with the hemangioma of the third metacarpal bone. Differentiated from a synovial sarcoma, fibrosarcoma, or a cartilage tumor. Vascular sinusoids, don't forget, because we mentioned in Maffucci syndrome, you can have phlebolith, but this is often associated with an enchondromal. Appears calcified. So you have to include this in the differential diagnosis. This is a hemangioma of bone from C4 and T12. See that there are sinusoids full of blood. This is a hemangioma of bone with multiple phleboliths. Old female with pain in the left iliac crest of 1 year duration. Note a large circular lesion in the central area of the iliac crest with a very dense flow surrounding a central lytic area with calcification in the center. This is confused with a giant osteoid osteoma or osteoblastoma, but this turned out to be a sclerosing hemangioma. This shows you the pathology. You see the numerous hemorrhage. You have widely dilated capillary sinusoids filled with blood lined by benign appearing endothelial tissue of a single cell layer, evidence of bone growing around the capillary sinusoids. One should note the surrounding connective tissue, which one could confuse it with a sclerosing osteogenic sarcoma. Coming to osteoblastoma, this is a very common lesion. I'm sure You all know about it. It's a benign tumor that you all know. It occurs mainly in the second decade, and the male to female ratio is 2:1. They account for 11% of benign and 5% of primary bone tumors as a whole. So it's quite a common lesion. It's characterized by pain, which is more severe at night, and relieved by aspirin in the majority of cases. Some authorities attribute this to an extremely high level of prostaglandin metabolites, which could explain the reason for pain. So don't forget, they have pain at night, it wakes them up at night. And if you're asking what causes the pain, you should say it's most likely prostaglandin metabolites, interleukin-6, etc. All of these tumor necrosis factors, all these together produce pain and pressure and injury to the nerve fibers. What was found that in the needles, we have certain nerve filaments that are bothered by these production of metabolites. The pain may be localized or referred. In the latter, if in the spine may be confused with a disc protrusion. It can also mimic any condition. For example, one may have a subchondral osteoid osteoma. This would mimic any of the joint diseases. This I tell you to the residents. Beware. You should make the difference between an intralesional problem and a subchondral osteoid osteoma. It has been reported in nearly every bone of the body. It is rarely found before the age of 5 and after the age of 40 years. The lesion usually involves the cortical bone, most commonly in the cortex of the femur and tibia. But in a quarter of the cases, it may involve the spongy neck of the talus, which is shown over here. I have had several cases of osteoid osteoma occurring in this region. When in the spine, it is localized to the posterior elements in 25% of the cases, mainly in the pedicles, lamina, spinous, and transverse processes. When it occurs here, it produces an atypical scoliosis. This is a question you always love to ask. It produces an atypical scoliosis that occurs at the wrong time and wrong place. And if you look at the lesion, it's usually in the region of the apex on the concave side. This is a question we love to ask. Abnormalities of bone growth have occurred. I'll tell you, I have had an osteoid osteoma in the proximal tibia. And what has happened? This patient gradually developed a valgus deformity to the extent that not being more than 1.5 centimeters in diameter. At the periphery, it is surrounded by a sclerotic zone. And centrally, there is a radiolucent zone known as the nidus, and with time becomes calcified. Technetium scintigraphy reveals marked uptake. To localize the lesion in difficult areas, a CT scan should be performed. But what I usually do, I do a technetium scan. I have an idea on what location, then I ask for a CT scan. Gadolinium enhanced magnetic resonance imaging has also supported the diagnosis. This is a plain radiograph in a 25-year-old man with a cortical osteoma. The lateral view of the right tibia shows a radiolucent needles surrounded by fusiform cortical thickening. Radionuclide bone scan. You see, we localized the lesion by a radionuclide bone scan in the 25-year-old man with cortical osteoma. It shows focal intense uptake of radioisotope corresponding of radiographic abnormality, which is consistent with osteoma. If you look at this plain X-ray of the pelvis, you see at the site of the arrow, and this is a 6-year-old child who presented with left hip pain. Shows a well-defined area of sclerosis surrounded by a ring of radiolucency in the femoral neck on the left side, and note the absence of periosteal reaction that suggests an intramedullary or cancellous osteoma. So this, take it as a warning sign. Depending on where the osteoma is present. If it is in cavity, you don't see so much sclerosis, so much reactive tissue around it. But when it presents in the cortex, it shows a tremendous amount of reactive tissue. This is confirmed by a radioisotope bone scan shown in the left hip with intense uptake, and this corresponds to the site of the abnormal radiograph of the hip. 8-year-old child is shown here, which presents with left hip pain and restriction of movement. An osteoma in the medial aspect of the femoral neck has resulted in periosteal new bone formation. This is another case at the tip of the distal phalanx of the big toe in a patient 24-year-old, and it shows of the distal phalanx with no periosteal new bone formation, suggestive of osteoma. This shows you the radioisotope uptake in this patient, confirming the diagnosis of an osteoma, and in the lesser trochanter showing the needles and the sclerosis around the lesion. In the spine, osteoma most commonly involves in the posterior ends, laminae, and pedicles, and it is the most common cause of a painful scoliosis. The level of the lesion typically corresponds to the level of the apex, as I mentioned, of the resulting curve, except in the lower lumbar region, the apex, the lesion. The lesion is on the concave side of the curve. Subsidence of the curve following excision depends on the lesion and curve. That's why when I get the patient that I've diagnosed with osteodystroma of the spine, the very first thing, if it is of short duration, then I assure the patient and the family that as I remove the lesion, the curve will correct. If the curve is longer duration, more than 1 year, then it won't correct. This is an osteodystroma shown in the lateral view of the thoracic spine in a 56-year-old woman who presented with abdominal pain, initial findings of chest radiography, intravenous pyelography, barium enema, and cholecystogram were normal. An isotope bone scan showed focal increased uptake in the vertebral body of the lower thoracic spine. Plain radiograph corresponded to the site of the abnormality, and it shows a radiolucent lesion in the posterior aspect of T11 vertebral body with surrounding sclerosis that was osteoma and later was confirmed at histological analysis. This is an osteodystroma of the sacrum, which is quite a common site to occur. This is an osteodystroma of the spinous process. This shows you the nidus and the zone of sclerosis. The nidus is heavily calcified, a loose space of meshwork of fibrotic granulation tissue, osteoblastic and osteoclastic activity with a fairly dense pattern of osteodeposition with evidence of calcification in the central areas of osteoid tissue. This shows you the nidus. One should distinguish this lesion from a bone island, osteomyelitis, sclerosing osteomyelitis, osteoblastoma, and osteosarcoma. The natural history is that the lesion gradually disappears or subsides over a period of 3 to 5 years. Excise the lesion, particularly the nidus, if necessary be. One may use burr down technique where we use the burr and we drill on down the reactive zone till we reach the hypervascular area of the nidus. Radiofrequency is used. We use it quite often nowadays. Now that we have developed experience with it, radiofrequency proposes a heating of 90 degrees. We don't use it in the region of the spine. At times we use freezing agents together with it. You can localize it with intra-operative tetracycline and operate and then remove the nidus. Osteoblastoma. I want to take a 5 minutes rest to rest my voice. Okay? 5 minutes rest. Of the spine. It goes down through the pedicle into the vertebral body. Common findings are the pathology, but osteoblastoma is not associated with so much pain as an osteodystroma. A factor about osteodystroma is that if you give aspirin, the pain will subside. This is a method of clinical diagnosis, so common to subside. So this is very important to distinguish between an osteoblastoma and an osteoid osteoma. Another important point is that there have been some osteoblastomas with aggressive. Two cases in the literature, quite common in the literature, that have metastasized to the lung. So you have to be aware. Now I'm showing you several cases of osteoblastoma. They are quite common. It occurs 40% involves the spine. The lumbar spine in a 52-year-old man who had the biopsy proven to be osteoblastoma and who presented with severe low back pain. The radiograph shows a well-defined in the left side of the L4 vertebral body. Centimeters in diameter. It accounts for only 3% of benign bone tumors. So it's kind of a bit rare. It involves spine more percent, and here it involves the posterior arches and may extend along the pedicles to reach the vertebral body. It may or may not be associated with a weird type of scoliosis. It osteoblastoma, the pain is relieved by aspirin. I have used aspirin as a mode of diagnosis of osteoblastoma cases. Radiographic appearance of osteoblastoma vary. Occasionally, osteoblastoma appears as a sclerotic lesion, and in other instances, it appears as a lucent expansile lesion. Findings in as many as 25% of the patients may demonstrate features suggestive of a malignant process, such as cortical thinning, expansion of the bone, and the presence of soft tissue mass. In the spine, it usually occurs in the posterior elements. It occurs in the pedicles and extends forward into the vertebral body. When a well-defined expansile lesion is identified in this location, a diagnosis of osteoblastoma should always be considered. Approximately of osteoblastomas in the spine contain matrix mineralization. Osteoblastoma in the skull produces a sharply marginated radiolucent defect containing central calcification or ossification, which is highly suggestive of the diagnosis. This shows you an osteoblastoma of the skull. The varied radiologic appearance of the neoplasm in sites other than the posterior elements of the spine and the skull does not allow a precise diagnosis to be made. The appearance of the lesion may resemble a large osteoblastoma with typical radiographic features of an edus with surrounding area of reactive bone formation. This is an osteoblastoma of the spinous process. This is a lateral radiograph of the cervical spine. In a 10-year-old boy, the spinous process of C3 vertebra is expanded by a mass with ossification. You have to realize this. This 10-year-old boy had an MRI, and it suggests a mass involving the posterior elements of the C3 vertebra. This shows you it on T1 weighted gadolinium enhanced sagittal MRI of the spine in a 10-year-old boy, and it reveals contrast enhancement of a mass occupying the posterior elements of the C3 vertebra. Likewise over here. So you have to learn that this does occur. This is an osteoblastoma with a lytic area at the level of C3, which shows over here on the CT scan. So radiograph of a left hip in a 14-year-old male adolescent demonstrates a lytic lesion in the intertrochanteric region of the left femur with faint, diffuse surrounding sclerosis. The long bones are the second most common location for osteoblastoma. This is a knee radiograph which reveals a somewhat poorly defined and non-specific loosened lesion in the proximal tibia, metaphysis of a 16-year-old male adolescent with lower leg pain. So look at the differential. You see it's surrounded by a zone of sclerosis, and in the center you have a radiolucent zone. This is an osteoblastoma radiograph of the right shoulder in a 39-year-old woman, which reveals a large lytic lesion arising in the proximal part of the humerus. This is an osteoblastoma of the talus. So I'm showing you several X-rays, several MRIs, several CT scans, so that when you get such a lesion, you have to learn to put a differential diagnosis. Likewise, these are cases, anterior posterior view of the pelvis. You have to think that it can occur in any region. Look over here. It's localized in the quadrilateral plate of the acetabulum. So you have to think of it. Think that this could be an osteoblastoma. Osteoblastoma, the axial CT image obtained through the tibial diaphysis, which demonstrates how osteoblastoma can resemble a large osteoblastoma with typical radiographic features of a central nidus with surrounding reactive bone. You see the zone of sclerosis. You see the nidus right over here. So you have to think of this. This is, you have to keep this in mind. What about the radiologic findings? It is expansive, radiolucent, with mottled opacities within the lesion, usually in the medullary portion of bone. It may be confused with an aneurysmal bone cyst. You have to keep this in mind. A CT scan and MRI are helpful in describing and localizing the lesion. The lesion consists of osteoid and woven bone. The osteoblasts are of benign appearance. The nidus of the osteoblastoma is larger than that of osteoid osteoma, with some investigators using 2 centimeters as a size distinction. If the nidus is eccentrically located within the bone, there is again a preosteal reaction, just as occurs within osteoid osteoma. The lesions may have radiographic features similar to aneurysmal bone cysts, eosinophilic granuloma, enchondroma, fibrous dysplasia, chondromyxoid fibroma, or solitary bone cysts. The presence of an osseous matrix within the lesion may suggest the diagnosis of an osteoblastoma. In patients in whom osteoblastoma simulates an aggressive tumor, neoplasms is osteosarcoma. This can be a simulation of osteosarcoma. Ewing sarcoma are in the differential diagnosis. Osteoblastomas in the long tubular bones may arise from the medullary or cortical bone. They usually appear as geographic lucencies with internal calcification and or ossification, and often expand the cortex. Surrounding sclerosis and periostitis, seen in as many as 1/2 of patients, can simulate an aggressive process and may be misinterpreted as evidence of a malignant neoplasm. Osteoblasts in the small bones of the hands, wrists, feet, and ankles, as well as in the flat bones. This is benign osteoblastoma. Of how it appears, it has the similar pathology of an osteoid osteoma. You see osteoid tissue cells, you see osteoblasts, but there is rarely any aggressivity. You don't see too much hyperchromatism. You don't see mitosis. This is a plain radiograph which shows a well-circumscribed containing matrix-type radiodensities, and note the absence of sclerotic rim. Why? Because and cortical expansion. The microscopic features resemble those of osteoid osteoma, osteoblasts, and osteoclasts, like giant cells, rim interconnected spicules of osteoid and woven bone. The intervening fibrous stroma shows prominent vascularity. There is no significant cellular atypia, as I mentioned, in osteoblastoma. The differential diagnosis is osteoid osteoma, osteosarcoma, osteoclastoma, even giant cell tumor, which is the same, aneurysmal bone cyst, and fibrous dysplasia. Excision is by either resection or curettage. The diagnosis of these entities resides exclusively in morphologic features, and although a variety of lesions should be considered in the differential diagnosis, immunohistochemistry offers little help in the distinction. Now we come to the benign cartilage tumors. Recent ability to identify a cartilage tumor and classify it into either a benign or malignant form is indebted to the immunohistochemical assay for S100 protein. This is a water-soluble, acidic calcium-binding protein originally thought to be specific to cells of neurocrest origin, but more recently described in normal human chondrocytes and some cartilaginous tumors. Malignant cartilage tumors are here again has been superior in demonstrating the medullary extent of the tumor. Benign tumors are avascular and malignant tumors are very vascular. Benign cartilage tumors, they give you a cold scan, is strong evidence that the tumor is benign. Patients treated for a benign cartilage tumor should be followed on a regular basis for a period of 2 to 5 years due to the risk of malignant transformation. Hereditary multiple osteocartilaginous exostosis. This represents the most common major genetic disorder of the skeleton. Bone scans are useful in detecting increased activity in a lesion that is undergoing alteration. It is a hematoma, osteochondroma. An abnormality grows a cartilaginous lesion that has a physis and growth plate with a stalk that arises from the metaphysis and grows along the pull of muscles away from the original. Plate. Usually they grow along the pull of muscles, along the line of pull. And you see that the medullary cavity of an osteochondroma is in continuity with the medullary cavity of the main or the mother shaft. A single osteochondroma has no hereditary transmission. Multiple osteochondromas are of autosomal dominant inheritance, and most are apparent at 3 years of age. They have a 1 to 2% malignant transformation. This is an osteochondroma that I had received. You look at the coarse and cancerous bone of the host. It may be pedunculated, cauliflower, or sessile. One of the questions we like to ask, which is most likely? But not a pedunculated. It does change, but it's less. Why? Because the latter two are on a larger surface area. Once the individual's growth ceases, it may resume growth following its arrest. With the rest of the growth in the body, here one should seriously consider it changing to a malignant lesion. It is the commonest benign lesion with an incidence of around 44% of all benign tumors of bone. The commonest area for it to grow is in the bones about the knee and proximal humerus. Plain radiograph is shown over here, demonstrates a pedunculated bony outgrowth at the proximal tibial metaphysis. The lesion had a uniform cartilaginous cap with stippled calcification. The tibial cortex and medulla were continuous with those of the lesion. There is no separation Cross-section through the lesion demonstrated mature uniform cartilage cap, less than 1 centimeter in thickness. Few small islands of similarly appearing cartilage were present in the stalk at the resection margin. Higher magnification of a cartilage cap shows mature, focally calcified hyaline cartilage. It presents either as a mass or due to pressure on neighboring structures, and this may elicit the symptomatology. In the spine, pressure may elicit nerve compression symptomatology. A sessile osteochondroma has a more chance of changing to a malignancy than a pedunculated one due to the larger surface area. An osteochondroma can present with trouble in the following ways: chronic irritation and bursts of formation, limitation of range of motion of the joint in the vicinity. It causes nerve compression, pain in a fractured stalk. This does occur, and they will present as such, and it may result in a pseudoaneurysm due to irritation of the vessels, and it may cause a gross disturbance. One should be aware of a second cartilage cap, more than 1 centimeter and 5 centimeters in width, as this could signify a maltransformation. This is best measured by MRI. The lesion consists of a stalk of normal calcareous and cortical bone, and at its end, a growth plate, quite similar to a normal growth plate. At this point, I would like to mention that once the growth of the individual ceases, this should cease. If the growth resumes, then it's a bad sign. It's a sign that is present. If you get this, and it's irritating a nerve, and you have to resect it in a child less than 10 years of age, you should always warn the family. We are fortunate it may recur due to the early age that we are forced to remove it. The cartilage cap regresses once growth ceases, but at any time following activity, one should beware of changing to a chondrosarcoma. So you have to keep this in mind, okay? It can change to a chondrosarcoma, osteosarcoma, fibrosarcoma, or a parosteal osteosarcoma, and this may occur in 1% of the cases. Excision is indicated if the lesion is large, irritative, resulting in pain, resumes its growth following cessation, and in lesions of the spine, where paralysis could be a risk or is setting in. This is an osteochondroma, and one shows that malignant transformation occurs in 1–4%. MRI and technetium scans are helpful in diagnosis. Why? Because it shows a nick, means that the lesion is growing again, and an MRI will tell you of a soft tissue component. So much for osteochondroma, enchondroma. Enchondroma is a mass of cartilage cells that have separated from the ossification center and become localized in the region of the metaphysis or persistent anillage of bone. These grow during the period of active skeletal growth, but once maturity is reached, it should exhibit little or no growth. The presence of calcification favor benignness. The overall incidence is 25%. The cells may consist of single or double nuclei within the lacunae and lie within hyaline substance. I'll tell you something, that the hand, for an enchondroma to occur, they involve the phalanges, the metacarpals, the metatarsals, and you can get a fracture. But these, if you take a spectrum, see that they seem to be aggressive, but yet they are benign as compared to other lesions. Another point I would like to mention about enchondromas is that you should be aware of enchondromas that are proximal, in the region of the pelvis, proximal femur, etc. So be aware of them to malignant change, and you should continuously follow them up. They are the most frequent benign tumors of the hand. Other sites include the humerus and the distal femur. In the hand, this has been commonly associated with cellular pleomorphism, but this has been insignificant as it rarely undergoes malignant transformation in this region. Enchondromas in the hands present as a mass or with a pathologic fracture. From 1 to 5% are the varied reports that undergo malignant transformation. This is more frequent in the proximal lesions. Enchondromas in the hands present as a mass or with a pathologic fracture. From 1 to 5% are the varied reports undergoing malignant transformation. So you have to pay attention to what I said. And this shows you an enchondroma undergoing a fracture, most common in the hand. This has a well-defined industrial margin, but expands the bone with cortical scalloping. There may be flecks of contained calcification. The lesion is of low vascularity. There's no periosteal reaction whatsoever. The lesion rarely extends to the ends of bones. Bones can show spore uptake if they're benign. Malignant change may occur in lesions in flat bones. Here, the lesion could be regarded as pre-malignant, especially in some families. There is an increased risk if tumors are multiple, especially Maffucci's syndrome, where hemangiomas are also found, and the incidence of malignant change in this case is 20%. Periosteal chondroma. I have had 2 periosteal chondromas in my life. They arise from the periosteum of the cortex. I have one in the clavicle and one in the tibia. Chondromas and enchondromas are 2 lesions with an identical histology appearance. And if the lesion is located centrally, it is an enchondroma. If the lesion is subperiosteal, it is a chondroma. The subperiosteal chondromas tend to occur in young patients. These are radiolucent lesions with sclerotic rims. A cartilaginous tumor that arises from the surface of the cortex deep to the periosteum, producing broad-based cartilaginous mass that may extend into the soft tissues, often develops after adolescence, in contrast to osteochondroma. It persists as a mass of mature cartilage with or without calcification or ossification, in contrast to chondrosarcoma. The tumor does not infiltrate into the adjacent soft tissue, but may increase in size. And this was in one of my 14-year-old girl patients with the lesion on the medial aspect of the clavicle that was growing posteriorly into the rib cage, into the lungs, that I was forced to excise. It consists of small surface mass. It's usually less than 3 centimeters and appears as a radiolucent oval or oblong defect on the periphery of underlying cortex. The lesion is underlined by a thin, distinct cortical reaction. Tumor has little or no calcification. In contrast to chondrosarcoma, occasionally there is intralesional calcifications and minimal periosteal reaction. Osteochondroma in a young patient is the radiographic differential diagnosis, juxtacortical chondrosarcoma, parosteal and periosteal osteosarcomas. These should be kept in mind because they all appear on the surface of bone. They arise from the cortex and periosteum. If you look at the parosteal osteosarcoma, it arises, but there is a clear zone. It does not penetrate into the medullary cavity. Okay, so please pay attention. In the periosteal osteosarcomas, they contain cartilage, occurs very commonly in the region of the tibia. This is the most common site. While the parosteal osteosarcoma occurs at the posterior aspect of the distal femur and proximal humerus. This is a low-power view and shows lobulated hyaline masses that are well circumscribed and is usually hypocellular and well circumscribed. Isolated areas of increased cellularity may be seen. The lesion is composed of benign cartilage, but it looks more active than in enchondroma. This lesion may be confused with a chondrosarcoma. Most of these lesions present in stage 2 and require en bloc marginal excision to prevent recurrence. Wide excision, including underlying cortex, is the treatment of choice. Now, this is what I did with the tumor that I had in the clavicle. It is important to remove the entire tumor, with or without rupturing tumor capsule. The risk of recurrence after block marginal excision is less than 10%, and more aggressive excision or adjuvant chemotherapy, radiation therapy are not indicated. This is a blotchy areas of calcification within the central areas of the double, may be more often seen in the proximal lesions. This is an enchondroma shown by CT scan, showing the calcification within the lesion. This is an inchondroma likewise. This is in MRI assesses the non-mineralized component of the lesion and may be of help in assessing aggressiveness of the lesion. Inchondromas demonstrate islands of cartilage encased by lamella bone, while chondrosarcomas can permeate the marrow, trap the pre-existing lamellae trabeculae, or can penetrate through the version. What is characteristic of a chondrosarcoma is that as it spreads in between the trabeculae and surrounds the trabeculae, but does not destroy the trabeculae. This is characteristic of a chondrosarcoma. This a lesion should be managed as a potential malignancy. One should differentiate this lesion from an epidermoid cyst in the distal phalanx, non-ossifying fibromas, chondromyxoid fibromas, chondroblastomas, and finally, even from simple bone infarcts. Epidermoid cyst, we all know that it occurs beneath the nail bed. You should let it enter the differential diagnosis, and these involve the distal phalanges, and they are treated by excision and, if necessary, bone graft. This is an inchondroma of the distal phalanx treated with kerygma of the lesion, bone grafting. So this enters the differential diagnosis with an epidermal cyst, as I'll show you. Oh, wait, let me see. This is an epidermoid cyst. So you should include this in the differential diagnosis, but it has no intralesional calcification. The epidermis, okay? Periosteal chondromas, they are rare. Emil, I'm giving a lecture. They are rare and arise from the periosteal tissues, and these patients usually present with pain. It is treated by marginal wide local resection. When incompletely, the incidence of recurrence is high. Olliers disease is a hereditary condition where one gets multiple inchondromatosis that are bilateral with unilateral predominance. Yani one side could be involved much more than the other side. It may be associated with multiple hemangiomas, and this is known as Maffucci syndrome. This shows you in Olliers disease. In this lesion is somewhat less prevalent, and histologic changes seen in these lesions are often interpreted by pathologists as showing more activity than the more common solitary inchondroma. 25% of these cases develop chondrosarcomas, out of which the majority are low grade. The pelvis and shoulder are locations that change to malignancy. Follow-up should be performed on a regular visit basis, and yearly bone scans should be performed. X-rays should be made, particularly in proximal lesions. So you have to know that osteochondroma, periosteochondroma, chondromyxoid fibroma, and inchondroma, immunohistochemistry has little or no value in the differential diagnosis of this group of tumors. Chondromyxoid fibroma is a rare benign bone tumor of uncertain histogenesis that expresses S100, a finding consistent with the cartilaginous nature of the lesion and supporting its possible relation to chondroblastoma. Little is known about matrix biochemistry and cell differentiation in chondrogenic neoplasms. Normal chondrocytes typically express vimentin, S100, and type 2 collagen. Neoplastic chondrocytes usually retain vimentin and S100 expression, but little else is known about the expression of other antigens, and it is assumed that malignant cartilage-producing tumors have no specific antigenic profile. Synovial osteochondromatosis is a benign condition characterized by synovial membrane proliferation and metaplasia. This entity is also termed synovial chondromatosis. This is a case, it's quite common to occur around the knee. You see that there are masses which undergo metaplasia of the synovial tissue. They separate and they have cartilage in it due to the change from synovial tissue to cartilage, and some are even ossified. The synovial lining of a joint, bursa, or tendon sheath undergoes nodular proliferation, and fragments may break off from the synovial surface into the joint. These fragments are nourished by synovial fluid. The fragments may grow, they may calcify, or ossify. These intra-articular fragments may vary in size from a few millimeters to a few centimeters. The degree of calcification varies, and calcification may be seen as a few calcific specks or as foci of frankly ossified bodies. The fragments may be found free within the joint cavity and may be embedded within the proliferating synovium, which may extend in the surrounding soft tissues. So, the natural history of synovial osteochondromatosis entails gradual progression of disease, joint deterioration, and secondary osteoarthritis. Essentially, the disease is benign, a benign process, and although recent studies in the literature have reported malignant transformation, this is decidedly unusual. The pathology is characterized by metaplasia, hyperplasia of the synovial membrane, and hyaline or myxoid gain. The synovial lining of the joint tendon sheath undergoes nodular proliferation. This is the pathology on these cases. You see the cartilaginous background, staining of hematoxylin and eosin. You see that it is not aggressive, but it is hectic. The fragments may break off from the synovial surface into the joint, and in this location, and nourished by synovial fluid, the fragments may grow, calcify, and lock repeatedly in the joint space between the two joint edges and destroy the cartilage. Synovial osteochondromatosis shows a predilection of 2 to 4-fold for males over females. All ages are affected, but the disease is diagnosed more often between the 3rd and 5th decades. Patients with SOC or synovial chondromatosis often relate a history of several years of joint pain with swelling. The affected joints frequently has associated limitation in range of motion or history of locking. It always is monoarticular, and the large joints are affected more commonly, including the knee, hip, and shoulder. However, the disease process may affect synovius, including extra-articular bursa. And these are, they have intra-articular fragments shown on plain films, MRI differentiate primary or idiopathic synovial osteochondromatosis from secondary osteochondromatosis. Secondary, the initial predisposing factor, is an unrelated articular process leading to joint disintegration, production of intra-articular fragments, synovitis, and synovial metaplasia. I have had a few cases like this that ended up having a total joint knee replacement. So you have to demonstrate the lesion. You can demonstrate that by CT arthrograms, and even MRI helps clinch the diagnosis. Ultrasound also has help. Radiographs should be obtained first, followed by MRI. MRI is not readily available. You do a CT with, these are the radiographs, CT images. Okay, and one should not confuse it with billonodular synovitis. An MRI image alone are available, and plain films may help resolve such a difficulty if it arises. So the differential diagnosis is billonodular synovitis. Tuberculosis, we know it gives rice bodies. Likewise, rheumatoid arthritis and synovial hemangiomatosis. T1 weighted and proton density images often demonstrate multiple rounded low signal bodies that are isointense or hypointense tumors. Some bodies demonstrate similar signal intensity to cortical bone. Some bodies may lie free, locked in corners, etc. T2 weighted images may show areas of high signal consistent with synovial thickening. Intravenous gadolinium, administered usually, enables differentiating diffusion from hyperplastic synovium, which shows heterogeneous enhancement. The joint effusion might be hemorrhage. You should distinguish the feature in calcification, which appears at signal voids within the synovium and visualized optimally with intra-articular fragments are calcified. This shows you a synovial osteochondromatosis occurring at the inferior aspect over the subscarius muscle, also around the glenoid. This shows it more, an additional one, and likewise. So all these help in making the diagnosis. For instance, over here, you see that there are even loose bodies in the tendon sheaths going to the supraglenoid region. So you have to think of this. This is another case, a third case, another case of the knee, of the elbow. You have to know these points. Okay? So keep this in mind. Synovial chondromatosis. They are all the same. You treatment, you do a synovectomy. Pigmented villonodular synovitis involves the knee in 95% of cases. It involves the hip and even other joints. Serosanguinous fluid was aspirated from the knee on multiple occasions, and X-rays show an enlargement of the synovium, nodular appearance, and cystic lesions in the subchondral region. You see cystic lesions on both sides of the joint. And you see that the tissue is brown due to hemosiderin, due to pigment which is present in the macrophages. This is the brown tissue, synovial hypertrophy, thickened villi, plump appearing synovial cells with occasional hemosiderin granules in their cytoplasm. You see polyhedral cells are subsynovial and originate from the reticuloendothelial system and are called upon to phagocytize the debris. Look at the brown tissue, heavy deposits of hemosiderin with many small reactive giant cells scattered throughout the field. So in brief, pigmented villonodular synovitis is a condition that occurs in the synovium. It involves both sides of the joint. It presents on plain X-ray with multiple small lytic lesions at the ends of both sides of the joint. There is no ossification or calcification within the lesion. It's a synovial hypertrophy. It's a huge amount of hemosiderin which deposits in macrophages. Fibrous cortical defects are quite common. They occur in children 4 to 8 years. Most of them subside with time. They grow out of them, and they are benign lesions. I'm not going to carry on more. This is a large fibrous cortical defect. And in this case, we should pay attention to prevent an insufficiency fracture. Many of these cases require bone grafting and correct mold. This is another fibrous cortical lesion. Plain radiographs show a sharply demarcated, loosened, loculated metadiaphyseal surrounded by a rim of sclerotic bone. The lesion predominantly involves the lateral portion of bone and produces a mild cortical expansion. Treatment is curettage. If it's quite large rattan tissue, you can follow these patients up if they're not large lesions, and you can assure that family most probably they will heal on their own. You see spindle cells, you see they are arranged in a storiform pattern, which is typical of fibrous cortical defects. You see also hemosiderin giant cell lesions. Giant cells are present in these cases. This shows you the histiocytes, the spindle cells are seen, hemosiderin-laden macrophages are seen. This shows you it. Okay, you discover them incidentally. Many of them can come in with fractures, especially if they're large. Don't forget that the cells common in the lesion are spindle cells, giant cells, hemosiderin-laden macrophages. And the treatment is indicated only in the latter circumstance where a stress fracture would be unavoidable, secondary to stress rises. Fibrous dysplasia. Fibrous dysplasia is a condition. I'm going to go very quick these last few because I want to finish by 7:30. It is a condition where bone is replaced by displaced bone with distortion of the normal bony architecture. Bone becomes soft, deformed, and as a result, they begin to have known to be a shepherd's crook deformity. These children have pain at the site of the lesion. It may be mono or polyanatomic, and these children may have precocious puberty. And if they have precocious puberty, it's known as Albright syndrome. And if you take a plain X-ray of the bone, it gives you a ground glass appearance. This is a patient who has fibrous dysplasia. You notice that it involves one side more than the other sides, and it involves the whole body. And there are cafe au lait spots. This shows you the pathology. You see areas of cartilage, walls of spindle cells. The earlier these lesions present, the worse the prognosis. In addition, osteosarcoma is known to complicate this lesion. These lesions are known for the high incidence of recurrence following correctement bone graft. Large internal fixation should be performed, preferably with an interlocking graft. This is another case of fibrous dysplasia. This is another case. You see the ground glass appearance of the proximal femur. You see that there is squaring of the metacarpal bones, okay, and calcific stippling. Likewise, over here, you see the appearance filled with smoke. It's a smoke character ground glass appearance. Over here, you see the alphabet. You see it appears like Chinese letters. If you take the specimen between the trabeculae, you see that the bone is not normal. You see woven bone. If you get a fracture, it does not heal easily. And if you have a lesion and you want to correct it and replace it with normal bone, most of the bone is resolved with time. This is another case of fibrous dysplasia with shepherd's crook deformity. Curettage of a specimen consisting of pieces of firm, white gray, gritty tissue. Microscopic examination shows markedly cellular fibrous tissue with a walled arrangement of bland spindle cells interspersed, slender curved trabeculae of focally calcified woven bone. This is what we call the Chinese characters. Osteofibrous dysplasia, Kawasaki disease. This occurs mainly in children at the age of around 5, and you see that cytokeratin is present in the lesion, and you see that it's typically a fibrous dysplasia, but not you have it cytokeratin in it, but you don't have it in fibrous dysplasia. And this lesion is related very commonly, quite commonly in the region of the knee. It can occur in the humerus. It was called Codman's tumor, and these lesions localize within the epiphysis, and it's mainly of cartilage tissue. It consists of chicken wire appearance, and you can see which metastasize to the lung. So you have to be very careful about this. This is another lesion. This is what we call the Codman's tumor. See the cartilaginous background. curettage material, cellular tumor consisting of sheets of round polygonal cells, multiple small foci, peak chondroid present during the vaguely lobular appearance. Many multinucleated giant cells are present. And you should see that there is a chicken wire appearance over here. You have to see this. And you see clefts, fine chromatin pattern, and occasionally inconspicuous nuclei. And this is the chicken wire appearance more clearly on microscopy. So you have to while in giant cell tumors, aneurysmal bone cysts, and other fibrous lesions, they do not, because these can occur in the same region. So most patients with chondroblastomas present with pain, which is often quite severe, and limitation of movement of the adjacent joint. It involves the epiphyseal region, and there can be zones of calcification of cartilage within the lesion. So you have to keep this in mind. And male patients are more affected. The average age at the time of presentation in several series was 22 years. Patients with a lesion that had not occurred in a long bone tended to be older than those with a long bone. Open growth plates have been considered to be a risk factor for recurrence. So you have to, it is believed that 20% of chondroblastomas have an aneurysmal cyst component, and you have to consider this. The only factors that seem to affect the recurrence is the anatomic location, and to a lesser extent, the method of treatment. The lesions in the proximal part of the femur, the greater trochanter, and the pelvis recurred, and the tumors in the pelvis, and then other that developed first in the rib, and then in the pelvis metastasized. You have to think of this. So some may be aggressive, depending on the location, depending on the age, depending on the surgical technique, because many times the physis will be open and the surgeon will be afraid to correct the lesion ratio. So these are for chondroblastomas. I cannot go include it. A chondroblastomas can involve the calcaneum and even the talus. This is in the talus. It does occur in the spine, but is extremely rare. This is a chondroblastoma in the patella, in the acromion. So it can occur anywhere along in the epiphysis. Don't forget, in the literature, one could note a number of cases of chondroblastoma that have recurred rapidly following excision and caused considerable destruction of local bone, and under rare circumstances, pulmonary metastasis. The pathology consists of chondroblasts that have a clearly defined cytoplasmic membrane within the chondroid, myxoid, and collagenous background. There are also irregular zones of calcification. Giant cells may also be present. This is a chondroblastoma, and you have to know a bit about the pathology. The treatment is curettage. I'll tell you this. Okay, so don't forget this. Because if you don't resect it completely, then recurrence will be high. So please don't forget this. Chondromyxoid fibroma, they occur at the periphery. It's most common in the tibia. It's a benign lesion with strict separation between it and the surrounding tissues. So it's rare. It's a benign tumor of bone that was described by Jaffe and Lichtenstein in 1948. Chondromyxoid fibroma is most commonly found in the long tubular bones, especially the tibia and femur near the knee joint. But it does occur in the ribs, it can occur in other bones elsewhere. Plain film shows a defined expansile lytic lesion in the distal fibula. Chondromyxoid fibroma is of unknown etiology. It is believed to be secondary to a translocation between the short arm of chromosome 3 and the long arm of chromosome 6. The tumor arises from cartilage-forming connective tissue of the marrow space. It is a lesion which consists of chondroid, myxoid, and fibrinous lesions. That's why we call it a chondromyxoid fibroma. And there is no evidence of malignancy. You can have focal calcification, you have giant cells present in the pathology. So I will not dwell further on it. Okay, you have to look at it. I'm opening this so that the recording will take place on chondromyxoid fibroma. Okay, so for you to look it up. Okay? I cannot carry on further with this tumor. So you should look into the literature, read about it, know where it occurs, know a bit about the pathology, and know about what type of management you will do, which is local resection and curriculum if necessary be. Okay, so this is enough for chondromyxoid fibroma. I have to go into other tumors. Yalla. I have a lot on chondromyxoid fibroma because I had a few cases. Osteosarcoma is the most common primary bone tumor. It's known to occur most commonly in the region of the knee. It can be osteoblastic formation of bone, it can be chondrogenic, it can be fibrogenic, and it can be vascular in nature, aggressive, very vascular, and this is called telangiectatic osteosarcomas. And nowadays, we are treating them in such a way, we're giving them chemotherapy as an adjuvant treatment. Of course, we have to do the same workup that I gave you at the beginning of this lecture. And once we've the diagnosis, we send the patient to the oncologist. He gives the patient either 3 or 4 cycles of chemotherapy. If we have a dynamic MRI or we inject gadolinium with an MRI, we can say whether this tumor is responding to the chemotherapy. And then this is followed by a limb-sparing procedure, and then the chemotherapy is continued. The prognosis has changed from 15% 5-year survival to 70% survival. So you have to pay attention. Of course, you have to go into the details. I cannot discuss too much more than what I have discussed on osteosarcomas. Please read. I asked from Dr. Khali to make copies and give it to you. Read and see what I have written because it's too long a lecture. As a matter of fact, I cannot talk anymore. So this is, you have to realize of how to do a limb sparing procedure. You have to have a bit of an idea on the telescoping prosthesis that we use, of how we pass the prosthesis in a magnetic field. The polyethylene which surrounds the instrument melts and the leg will lengthen a few millimeters that often, because we're getting complications from it. Let me see. Okay. You should know a bit about the chemotherapy, what are the ones that we use, the combination, and the results. You should know about UVIS. What UVIS did, he measured the amount of cell necrosis. If the necrosis is more than 90%, it's good osteosarcoma. It indicates that the prognosis is good. If you're doing a limb sparing procedure, you should judge whether you can do it or not. If the vessels and nerves are not involved, if it's not too distributed, then you can do a wide marginal resection and then insert your prosthesis in. So this is as far as osteosarcoma. But beware that telangiectatic can imitate an aneurysmal bone cyst, and you think it's a benign malignant lesion, and you would have problems. Okay, so please don't forget this. Okay, now let's come to Ewing's. You know, don't forget that you have the parosteal osteosarcoma and you have a periosteal. The parosteal, you see that the cortex is intact. The lesion is not going in. And that's why we call it parosteal. The prognosis is much better. It's a slow-growing tumor. And if you resect this portion, the patient will be treated and have a good prognosis, and you don't give these patients chemotherapy. In the periosteal, which is localized mainly in the region of the tibia, you see a cartilaginous component, and this is more aggressive, and therefore you have to do a more aggressive dissection on it. This is the periosteal. Then occurs in patients 15-25. It's extremely rare. Clinical present pain is the most common. Most common location is in the femur or tibial diaphysis. The lesion has a sunburst periosteal elevation in the diaphysis of long bones and in the underlying cortex, may be saucerized, and you have to resect this, probably do an intercalary resection and use internal fixation. And as a matter of fact, this is a patient that was present, and you have to know how you should follow up these patients. Metastasis occurs in periosteal osteosarcoma in 25%. Beware of this. And don't forget it. Okay? And then you have dedifferentiated osteosarcoma. This is telangiectatic, it's rare, containing large blood-filled spaces. It's similar to classic osteosarcoma. And 25% present with a pathologic fracture. It's a typical lytic lesion. It can be complicated by an aneurysmal cyst, or you have to include it in a differential diagnosis. This is such a lesion, and you have to do prosthesis. you give the adjuvant and the post-surgical radio chemotherapy. When you have a fracture, it does not change much the treatment, especially in osteosarcoma. This is a fibrous histiocytic tumor. It is a primary malignant bone tumor, similar to osteosarcoma, but with histiocytic differentiation and no osteoid. It occurs in patients 20 to 80 years. There is a slight male predominance. Genetics and etiology, 25% of cases occur as secondary lesions in the setting of a bone infarct, Paget's disease, so don't forget this, and prior radiation. This is another lesion. And they present with pain, swelling, and limp. It occurs quite commonly in the region of the metaphysis. Gives you a lytic picture by plain radiography. There's no bone formation. There's only cortical destruction. And this shows you the lesions. So you have to keep this in mind, okay? Fibrosarcomas are rare, spindle tumors. They are rare, and they have spindle cells. Pain is predominant presentation. It most commonly occurs in the femur, and it can arise on existing lesions like fibrosarcoma, radiation, or an infarct. And this shows you the plain X-ray appearance of a fibrosarcoma. And the histology is a spindle cell arrangement in a herringbone pattern vesicles, and it can occur in low to high grade variants. Differential diagnosis includes desmoplastic fibroma, and you see multiple mitotic figures. This is the pathology. High power histology of a fibrosarcoma of bone reveals moderate atypical spindle cells arranged in a herringbone pattern along with collagen fibers. And the treatment is surgical. Cartilage tumors, I just want to mention that cartilage tumors consist of chondrosarcomas, but you have several varieties. This typical one is a central chondrosarcoma. Then you have a clear cell chondrosarcoma, which arises in middle-aged adults in the epiphysis. You have a mesenchymal chondrosarcoma, which is a round cell appearance. And you have dedifferentiated chondrosarcoma. You have to pay attention. Quite a number occur primary, but others occur secondary. And you have to follow up your patients, especially patients who have enchondromas in the proximal bones, namely the pelvis, proximal femur. Be careful. Patients have osteochondromas who are regrowing, have a thick physis. These you have to watch out for dedifferentiation. Okay, so pay attention to this. And the treatment is surgical. Chemotherapy and radiation therapy have no effect whatsoever. And you should distinguish the grade 1, 2, 3, 4, depending on the activity of the cells, depending on how much hyperchromatopsia, depending on how much mitosis. All these have a lot to do with it. You have to read this, okay? So enough for this. And lastly, I would like to mention about Ewing sarcoma. Please read these, read what I have written, because really I don't have time to give you all the topic incomplete. Actually, I don't have any voice left So please read the subtypes, know what are the types of chondrosarcoma. I have them down listed. This is a clear cell chondrosarcoma. You have to know the pathology. So this would tell you. You have to know about the mesenchymal chondrosarcoma, which is composed of biphasic pattern of cartilage and small round cell. And this shows you a lot about the condition. Okay? Then you should know about the round cell lesions, the Ewing sarcoma, which has CD99 positive. It arises in the diaphysis. It arises in young children. It's common to occur in the femur and in the tibia. It can occur in any bone, but it can occur in flat bones at the same time. And it's characterized by round cell formation in microscopy, and it gives you a rosette formation. Rosette, the cells, the round cells, surround the necrotic area. This tumor grows at the periphery. It's characterized by either a onion peel appearance or by a sunburst appearance. It's very necrotic. In elevated sedimentation rate, you have to know that African Americans and Chinese, it's very rare. And it's male to female ratio 3:2. And this is the second most common primary bone tumor in children. 80% are younger than 20 years. And you have to know about the condition, how they have pain, swelling, frequent fever. The ESR, LDH are high with white blood cell count. This is a bad prognosis. The most common locations are the pelvis diaphysis of long bones and scapular. You have staging workup includes a bone marrow biopsy in addition to standard studies. Imaging, purely lytic bone destruction, preosteal reaction, polymarginated. It has a permeated pattern. So you should not forget these lesions. Let me see if there's anything more left for me to discuss. Notochordal chordomas, you know that it occurs at the spheno-occipital vertebra very rarely. Most commonly, it appears in the sacrum. This is a notochordal remnant tumor. It consists of 5 celliferous cells or signet cells, and the treatment is by excision, removal of the sacrum. Depending on how much you remove, this will tell you about the functional results of the patient. This shows you one in the sacrum. This is the mobile spine, and this is in the spheno-occipital region. So it's signet cells. So tumors occurring in the vertebrae are giant cell tumor, metastatic. So you have to know about the pathology, about the special stains that we use, and then adamantonoma, which is an epithelial type of tumor occurring in the mid aspect of the tibia. It's a slow-growing mass. They are 20 to 40 years old. They present with pain. you have tenderness, and this shows you it. You have to know about this. Nests, this is the pathology. Nests of epithelial cells in benign fibrostroma. Epithelial cells are columnar in appearance and keratin positive. Epithelial cells are bland without mitosis. And you have to know about these tumors. Multiple myeloma, you all know, it's a round cell proliferation, plasma cells. It involves the immunoglobulins, IgG and IgA, and it occurs in the elderly. It is the most common tumor of bone. It starts with multiple punched out osteolytic lesions. And let me see if there's anything more. Electrophoresis helps you in making the diagnosis. Let's see over here. What these are multiple myeloma. It involves the vertebra quite commonly. Okay, it can be localized or in the form of solitary, and you can have it in osteosclerotic myeloma, which will give you an ivory vertebra. If somebody asks you what is the differential of an ivory vertebra, it can be prostate cancer, it can be Paget's disease, it can be osteosclerotic myeloma, or even lymphoma. So pay attention, this enters the differential diagnosis. You have to read these, you have to know them. Okay, secondary lesions, think of post-radiation sarcomas, you have to think of them, you have to read them. All these are as a direction of what you should read and what you should study. Okay, so read them. And these are top. I'm going to go through this. Osteosarcoma classically occurs in the metaphysis of long bones and presents with progressive of bone destruction and bone formation, starting in the medullary canal. The osteoblastic stroma cells are malignant in osteosarcoma. The 5-year survival of patients with osteosarcoma has gone up 65 to 70%. Parosteal and periosteal occur on the surface of bone, but parosteal osteosarcoma is low-grade that appears fibrous histologically and treated with wide surgical resection. Periosteal and intermediate grade lesion that appears at chemotherapy and surgical resection. Telangiectatic or be confused with aneurysm bone cyst. So you have to know this, okay? Radiation is not used in the treatment of chondrosarcoma. You have to know this. Benign. And in the site of previous lesion or site of radiation is suspicious for a secondary lesion. Radiographic appearance of a secondary trauma, a secondary sarcoma, is an aggressive, destructive bone high-grade sarcoma, osteosarcoma, malignant fibrocystoma, fibrosarcoma, and chondrosarcoma. Okay. Secondary squamous cell carcinoma can arise in long-standing osteomyelitis. You should know this. يمكن فرجوكم case of osteomyelitis with secondary squamous cell carcinoma. You have to know this. Secondary chondrosarcomas can occur in prior chondromas and osteochondromas, more commonly in patients with Ollier-Mafucci multiple hereditary osteochondromas. And thank you. شو خالد؟ خالد يا خالد
شكرا لك.
لك يا خالد بعد بقدر اعطيكم 4 ساعات، شو رايك؟
شكرا لك، الكل يعني بيتشكروا منك وتعبناك يا باشا.
يا خالد لازم الشباب شو قالوا؟
بيتشكروا منك.
بس بدي اقول لك لازم ياخذوا هاللكشر ويدرسوها.
أيوة.
I'm sorry ما اعطيتهم ديتيلز عن الاوستيوساركوما واليوينج ساركوما، اعطيتهم الهايلايتس طبعا.
ايوه احنا مسجلينها
They should read it and get used to it. They should read it and get used to it. الجمعة الجاية رح بعطيهم على hip replacement arthroplasty, total hip replacement. Okay, everything to do with it. Yalla, have a good day. Thank you.
شكرا. Thank you very much.